Well, welcome to everybody. Thank you so much for being here. It's fun to see where people are joining this webinar from. My name's Jordan Karp. I am professor and chair for the Department of Psychiatry in the College of Medicine here at the University of Arizona in Tucson. I also serve as clinical service chief for behavioral medicine for Banner University Medical Center and Group here in Tucson. And I'm also a board certified geriatric psychiatrist. We're really pleased that you have decided to spend 4 hours of a precious Saturday with us for our third installment of the Psychiatry for Non-Psychiatrists University of Arizona Update in Behavioral Medicine for Primary Care. I promise you that this will be time well spent. We've selected topics and speakers that will keep your interest, improve your clinical skills, hopefully entertain you a bit, and most importantly, improve patient care and patient outcomes. Our first two conferences were incredibly well attended, and the attendance for this one has doubled, and we are at a staggering 322 registrants as of this morning. I think this really shows that we are still struggling to meet the needs of patients with psychiatric conditions, especially older adults who require behavioral health care. So recognizing the pressing need for improving the knowledge and skills of primary care providers in geriatric mental health and geriatric psychiatry, we created this educational activity to enhance the clinical skills of primary care providers, social workers, psychologists, pharmacists, physicians from other specialties in providing high quality care for late life mental illness and the behavioral symptoms associated with neurodegenerative diseases. There are not enough psychiatrists, psychologists, or social workers to meet the demands of older people who need mental health treatment. We know that this shortfall is particularly dire in rural regions, many urban neighborhoods, and community mental health centers that often treat the most severe mental illnesses. Here in Arizona, about 40% of Arizonans live in a mental health care professional shortage area, and 61% of Arizona adults experience mental illness but don't receive treatment. However, this is not just an Arizona or a US problem. This problem is international. So the question then is, how do we respond to the clinical needs of so many older patients and improve access? Well, we can certainly try to train more psychiatric residents, psychology interns, psychiatric nurse practitioners, social workers, licensed professional counselors, and psychiatric pharmacists, and we are working on this. But that takes time, because to train a psychiatrist, they have to complete 4 years of medical school, 4 years of residency, perhaps another year of subspecialty fellowship training, and we don't have time to wait for another 8 or 9 years. Another solution is to train primary care providers in the assessment and care of common psychiatric conditions in older adults in the primary care setting. In general, PCPs are more likely to provide psychiatric care rather than refer their patients to mental health specialists, partly because it's so difficult to access and navigate the mental health care system. This is why we knew a conference like this would be valuable to primary care providers. So again, I want to thank you for honoring us with your presence and your commitment to learning and improving your clinical practice. I want to express tremendous gratitude to Banner University Health Plans and our good colleague and Chief Medical Officer for Banner University Health Plans, Dr. Sandy Stein, for their generous support of today's CME eligible activity. BUHP operates as one component of an integrated healthcare system, Banner Health, which includes Banner University Medical Center Tucson campus and the South Campus, as well as a comprehensive network of Banner Health primary care and specialty care providers. The health plan includes a Medicaid complete care program, Arizona Long-Term Care System, or ALTICS, and Banner Medicare Advantage Dual for members with both Medicare and Medicaid, HMO and PPO programs. I want to specifically shout out to Banner University Healthcare Arizona Long-Term Care System for their support of this today's program. And for veterans, either veterans you're taking care of or other veterans in your life, it's important to note that there might be additional benefits on top of ALTICS to better support their long-term care requirements. So again, thank you, Banner University Health Plan, for your dedication to ensuring the people in our communities who are among the most vulnerable and for your support of today's program. I have just a few housekeeping notes to share before we get started. Please use the chat function for asking questions. I'll be moderating the questions and asking our presenters a couple of the questions that are posed. This is because we're on a tight schedule with just 5 minutes for the question and answer sessions. So please be sure to stick around until the Ask an Expert session at 11:40 this morning, and any questions that we don't get to during the course of the day, we'll address those then. We also ask that the chat feature be only used for questions to our speakers or potentially for answering your colleagues' questions. As healers, we know how important it is to be kind and respectful, but to cover our bases, we do want to share that anyone who posts disruptive or disrespectful language in the chat will be removed from the webinar. With the reminder for today's event, you should have received information that included the conference learning objectives, the conflict of interest disclosures, and the link to fill out the evaluation survey. Jamie will also post the link to the evaluation survey toward the end of the program. Once you fill out the evaluation survey, you'll receive a link to submit the request for your continuing education credits, and those certificates will be issued by mail at the end of November, along with a link to the recording of today's conference. If you have any logistical questions during today's event, please reach out to Jamie Manser at her email at jlmanser, that's JLMANSER, at arizona.edu. So I'm to introduce myself. Again, I am the department chair and professor of psychiatry at the University of Arizona College of Medicine in Tucson. I'm the medical director for behavioral health technology for Banner Health, and also the clinical service chief for Banner University Medical Center. And I have expertise in the fields of geriatric psychiatry, depression treatment, and suicide prevention. I am a clinical psychiatrist, an educator, and a clinical trialist. And for the past 2 decades, my research has focused on studying and trying to improve outcomes for older adults with difficult to treat depression. So with that, let me begin my talk. So I'm going to be speaking about difficult to treat depression in late life, getting to remission. My disclosure slide. And this is the agenda for my talk today. I would like to start with some definitions and scope of the problem, talk about what is unique about difficult to treat depression in older adults, and some moderators or predictors of disease response variability that matter, when to refer, some algorithms to get to remission, and third, fourth, and fifth line approaches to care. So let's start with the rationale for treating depression in primary care. And this is language that I frequently use with my patients, and I consider depression to be a medical condition with psychological symptoms. And we know that depression can worsen comorbid medical conditions and contribute to all-cause mortality, not just from suicide. It makes our platelets stickier, it decreases cardiac conduction variability, it impairs immunity and worsens cognitive function, and also can worsen vascular health. And especially in older adults, but really across the lifespan, I'm always thinking about these 3 Ds when I'm caring for depression. Depression, diabetes, and dementia are a really toxic triad, and we know that both depression and diabetes worsen the risk and the symptoms of dementia. When taking care of older adults, really a precept of geriatric medicine and geriatric psychiatry is to attend to what matters most to our patients. For many older adults, that's quality of life, vigor and energy, being able to sleep well, spending meaningful time with family and social networks, maintaining finances and independence and aging in place, and finding internal peace, joy, and being pain-free. All of these are impacted by depression. All of these conditions and things that matter most have an interaction with depression that makes them so much more worse and burdensome for patients. So treating depression is important for these things that matter most to older adults. Finally, we need to remember that disease silos in medicine are artificial. And like it or not, treating depression is a job responsibility of primary care providers. I like this rubric of the natural history and the treatment course of depression and the 5 Rs of depression treatment. And in many of my discussions with primary care colleagues, they feel overwhelmed with what to do next or how to conceptualize the treatment of depression. And this in some ways mirrors oncology treatment with acute continuation and maintenance treatment. But let me walk you through this. So the y-axis here is severity of depression symptoms. Lower part is more severe depression. The x-axis is time. And look at these 5 Rs. So response, remission, relapse, recovery, and recurrence. So let me walk you through a patient journey. If somebody presents to treatment because they've become syndromal, we want to get them to response, which is about 50% improvement. But the goal is to get to remission, where they are almost completely free of symptoms. They may then move to continuation treatment. And during this period, if they get sick again, we would consider that a relapse. If they have made it through this period, which is often about 3 to 4 months, we could consider them to be recovered. And they may or may not receive maintenance treatment, depending on whether they have a recurrent form of depression. But if they get sick again during maintenance, we would consider this to be a recurrence, so a new episode. This is not just academic. This helps me to conceptualize if somebody has a single episode or recurrent form of the disease, and if they need to be in maintenance treatment, and helps to guide when I should consider maybe stopping an antidepressant. I also wanted to just share about the burden. This was published in 2002, so about 20 years ago. The impact on quality of life and economic productivity of depression matches that of heart disease and surpasses the burdens associated with arthritis, hypertension, or diabetes. Suicide, especially in people with mood disorders, remains a leading cause of death. And this is an important statistic to remember, that suicide in North America is the 10th leading cause of death. Finally, the direct cost of treating mood disorders pales in comparison with the costs associated with decreased productivity, sick leaves, and premature death. This has been repeated over and over. I just think that it's worth sharing that 20 years ago this was published, and we are sort of in the same boat in some ways. Well, when should we screen? And the United States Preventive Services Task Force suggests that we should be screening in the general adult population, including pregnant and postpartum women, and in older adults, and it should be done when there's adequate systems in place to ensure an accurate diagnosis and effective treatment. Patients want to be screened for depression if they know that there's a rationale, and this is a project or a study that was done in cardiology, but it can promote the validation of their symptom burden and legitimizes the display of psychological distress, especially in cardiac practice here, but I think this is relevant for primary care as well. Now, this is different from when I go to the primary care physician, and maybe this is your experience too. The MA comes in the room and they ask me if I've fallen, if I feel safe at home, and if I'm depressed. And I just say no to all of these. I don't really, it isn't the best way of asking about depression. And then I think that it's really sharing that the rationale and providing an opportunity for discussion is what patients are interested in. Well, how to screen? You can simply say, tell me about your mood, or do you think that you are depressed? I recommend possibly using the PHQ-9, which is the two cardinal symptoms or questions of the PHQ-9 and the GAD-7. So it's asking about anxiety and depression, which can then guide further screening using the PHQ-9 or the GAD-7, and a score of 3 or more for each, either questions 1 or 2 or 3 or 4 suggests continued screening. In older adults, the frequency of screening is not really established, but just use common sense. So older adults who are disabled and have poor health status, complicated grief, chronic sleep disturbance, loneliness, or a history of depression should be screened. In general, I recommend if a patient is new to you, they should be screened. And if they have, after considering risk factors, either every 6 months or when there's a change in health or psychological or psychosocial status. Taking a depression history has not really changed from when you were in medical school or nurse practitioner school or psychology or social work school. It is still SIG-E-CAPS. To really diagnose depression, we like to have the two cardinal symptoms, low mood or anhedonia or lack of pleasure. In many older adults, especially those who are starting to have some neurocognitive symptoms as a result of neurodegenerative disease, we may see depression without sadness. So more anhedonia, more apathy, or a lack of being able to actually describe their internal experience. I want to know the duration, the triggers, the severity, how the depression impairs them, and social determinants of health that are contributing to this episode of depression. When I take a history, I'm asking about their experience with previous episodes because, again, I want to know if this is a single or recurrent form of the disease, their current treatments, dose and duration, and previous treatments that have worked or not worked or have been difficult to tolerate. I want to know about family history, a history of suicide attempts and hospitalizations, and I will frequently ask, is this the most depressed you've ever been? Have you ever been so depressed you couldn't get out of bed, or are there days that you don't even get dressed? I'm not going to read this list of comorbidities, but these all contribute to challenges in getting people well, and I'll just pause for about 10 seconds to let you review this list that we should be attending to during our histories. So let's define difficult to treat depression. And I have an asterisk here because often we use the term treatment-resistant depression. And I think difficult to treat depression is actually a kinder term because there's already enough stigma and patient blaming and patient shaming in mental health care. But a generally accepted definition of treatment-resistant depression is the failure to respond to two different antidepressants of adequate dose and duration during the acute phase of treatment. So we already looked at this curve earlier, and if this is the acute phase of treatment, this would be saying that, well, we tried two different antidepressants and they didn't get well. Well, what about these people here who maybe had a relapse or a recurrence? I would say that they also have a difficult to treat depression, but they may not meet this, while it's not universally accepted, a commonly used definition. Let's try to use the term difficult to treat depression for the rest of today's talk. And I think we could define it as depression that continues to cause significant burden despite usual treatment efforts. I don't want to read everything on my slides, but I will say that perhaps a key to this definition is that it is patient defined. The patient perceives their disease as difficult to treat. And maybe instead of any or just two antidepressants, it could be they've tried treatments of different modalities, psychotherapy, medications, neurostimulation, other integrative treatments at adequate dose and duration, and it hasn't brought about a resolution of their disease. It could be due to non-response, intolerance, they couldn't accept it, or there was a contraindication. The last thing I'll leave you with as we think about difficult to treat depression, this definition and how it may differ from treatment-resistant depression is that TRD focuses exclusively on the acute treatment phase. And it's acknowledged that if we think about difficult to treat depression patients, and these are the patients that we see in the clinic, will encompass a more heterogeneous group. And I think that that's fine, but I'm hoping that this will give you maybe a better more confidence in thinking about the kinds of patients that have more challenging to treat depression. Well, what are some patient and illness-related characteristics contributing to difficult to treat depression? Well, older age, any childhood maltreatment, an onset greater than 60, substance use, recurrent episodes, suicide risk, quality of remission, and comorbid medical illnesses. I included the odds ratios of some of these characteristics. I want to draw your attention to the quality of remission. And let's come back to this figure again. For some older adults, especially those with significant anxiety, medical conditions, or neurodegenerative disease, or prodromal dementia, or frank mild cognitive impairment or dementia, their remission may be more brittle. So this is what I frequently see in some of my older adult patients who I have gotten to response or remission, but they have a less stable response. Remission. This doesn't mean that we can't get people well and keep people well. It means that for some older adults, they may need some more attention. With more frequent visits, we may need to engage the family in helping to monitor symptoms and using behavioral activation or making sure that they're actually taking their medicine to stay well. But this is something to be attentive to. Well, we talked about these patient and illness-related characteristics, but what about older adults? And like so many consensus statements about mental health care, the unique features associated with aging are often excluded. So what do you think may be missing from this list? I think that not talking about cognitive function, in particular, mild cognitive impairment or dementia, and disability and frailty are things that we need to be considering when we're caring for older adults. Certainly, neurological, cardiopulmonary, metabolic, and rheumatologic diseases can contribute to a more difficult treatment course. Grief, loneliness and social isolation, obstructive sleep apnea, and fear of falling. So we do have some treatment goals for treating difficult to treat depression. We want to strive for optimal symptom control. We want to reduce the risks and impact of relapse. We want to optimize psychosocial functioning. We don't just want people to be in recovery. We want them to be engaging or re-engaging in life. So how do we do that? We make sure that we have good rapport and they are engaged in treatment. We use shared decision-making so that they feel that they are part of their treatment planning. We support self-management strategies, so healthy behaviors, limiting alcohol and drug use, reducing smoking. I can't reinforce this enough. We recommend the implementation of measurement-based care, so serial PHQ-9 scores or GAD-7 scores and serial assessments of side effects so that we can adjust the course of treatment, and then a frequent reassessment and consideration of the treatment direction so we don't get stuck in clinical inertia. And we use this information, these goals and principles, to come up with an integrated service pathway. It doesn't always work, though. And when should you refer to a mental health specialist? So if somebody is at elevated risk of suicide or they are psychotic, I'm using the term treatment resistant here, but if they have a difficult to treat depression and you feel like you're out of your element, if they have bipolar disorder that is not stable or is compromised by addiction, and if there is diagnostic uncertainty, and this is frequently observed in older adults who may have neurodegenerative disease, either frank or it's prodromal, which complicates the presentation. If there's personality traits interfering with medical management, again, neurodegenerative diseases with emotional changes, or excessive case management needs. So let's talk about this case example. Should you refer? So this is a 76-year-old retired female teacher. She meets criteria for a 5th lifetime major depressive episode. She's compliant with nortriptyline at an adequate plasma level and olanzapine, sort of maybe a combination that challenges the comfort level of some primary care providers. Family history of bipolar disorder, numerous motor vehicle accidents with some traumatic brain injuries. She's tried to kill herself twice. She's been treated with 4 different antidepressants and has had ECT. Multiple medical comorbidities. She smokes and uses marijuana edibles. She lives in a trailer. She speaks on the phone, but she's resistant to video visits. You're wondering if it's maybe because she has some hoarding behaviors and she's embarrassed or ashamed of her environment. She doesn't drive, she's falling, and she says she's increasingly misplacing objects. I know that everybody on this call today has had patients like this. And should you refer? Yes, of course. I just wanted to reinforce that these are some of the examples that you're going to see, or that you do see in your clinic, and you are not alone. These are cases where you certainly should seek some mental health assistance. So I want to share some clinical pearls to attain a more useful clinical history. Please remember to screen for obstructive sleep apnea. If you're not familiar with the stop bang assessment, it's easy to implement in primary care. Screen for alcohol, marijuana, and opioid. I've been shocked. I shouldn't be shocked, but I have seen several older adults in their late 60s and 70s here in Southern Arizona who use meth. Really any disorders that activate the reward system and can disrupt sleep. That it also includes gaming and excessive social media use. screen for benzodiazepine misuse, especially benzodiazepine misuse comorbid with alcohol misuse. I ask about adherence, and my goal is to get people to take their medicines at least 80% of the time. Less than that, and it's likely that you're not going to have a clinical benefit. And again, screening for bipolar disorder, if people are not getting well, makes sense. And you can simply ask, have you ever been the opposite of depressed, euphoric, or incredibly irritable for many days? Learn to take an actionable sleep and insomnia history. And again, for all patients 70 and older, administer an annual cognitive screen. So I want to consider some processes of care to improve difficult to treat depression outcomes. I like this consensus statement from the Canadian Association of Geriatric Psychiatry. This is the pharmacopoeia that I follow from the different steps of treatment. And each step is about 6 weeks, but I make sure that I get people to the FDA-approved dose, or at least the highest tolerated dose. But let's talk about the processes of care that actually get people well, because this is evidence from my own and colleagues' published data. The response rates for treatment as usual of depression in primary care are not good. They're about 20%. If we use collaborative care, so it's a depression or nurse care manager who has a panel of patients in primary care, they're supervised by a psychiatrist, they provide telephonic psychotherapy support to the patients, and they talk with the psychiatrist who makes medication recommendations, and the depression or nurse care manager then communicates that to the primary care physician who places the orders. So this is really a primary care-based type or model of care with psychiatric support. We can get about 40% of people well. What about people receiving placebo in a randomized controlled trial? Well, about 30 to 40% of people receiving placebo in an RCT get well, about as good as the number of people who get well in collaborative care, and about twice as good as treatment as usual. So you are better off participating in a high quality clinical trial and receiving placebo for your depression than having an antidepressant prescribed by a physician in primary care. Now, this is general, of course. I'm sure people are saying, well, my patients get better. But let's talk a little bit more about some of these processes that may contribute to the high placebo response rate in randomized controlled trials. So this is the usual care, 20% response. It's based on the physician and patient availability. If we're lucky, 2 to 3 visits over 12 weeks. That's a pretty liberal estimate. The duration of visits may be 10 to 20 minutes. Treatment protocol, we try to individualize it for each patient based on their characteristics and preferences. Maybe we have a large number of antidepressants and we don't have a sequential approach. The dose titration and change in treatment is negotiated at each visit with the patients based on their perceived adverse effects or lack of improvement. Monitoring of symptoms and adverse effects is sort of spontaneous and ad hoc. And the main focus of the clinical interactions is negotiating whether and how antidepressants should be used, titrated, switched, augmented, not very systematic or algorithmic. In experimental conditions, in the types of a high quality randomized controlled trial with a placebo, there are fixed visits. There are often 4 to 6 visits over 6 weeks, and then 6 to 12 visits over the course of several months. They last longer. The treatment protocol is predetermined. There's minimal adaptations based on the patient's characteristics, although it may be reduced if somebody is frail. We have a small number of antidepressants that are pre-selected based on the best evidence or guidelines and used in all patients. Again, the dose titration is predetermined. It's based on measurement-based care. So if you're using serial PHQ-9s and your plan is to increase the dose, if patients are still above a PHQ-9 of 10, then that's the algorithm you would follow. To monitor symptoms and adverse effects, we systematically monitor these with the use of structured interviews and validated scales. And the main focus of the clinical interactions is maximizing treatment adherence with psychoeducation, characterizing and sharing using measurement-based care data their changes in their symptoms with the patients and managing adverse events. So my 5 tips for successful treatment of late life depression in primary care. Clarify whether it's single episode versus recurrent based on that curve or figure I showed you a couple of times. I charter a course, I try to instill confidence, and I set expectations using my expertise. Sometimes I think we do a little too much. I mean, shared decision making is important, but a primary care physician doesn't say, well, here's 3 different hypertension medicines. Which do you think we should use, or which are you most comfortable with? I will say things like, let's consider treatment as an experiment. If what I'm prescribing doesn't work, I have a plan for the next step. Or I consider depression treatment in 6-month chunks of time, because many patients don't like the idea of being on an antidepressant for the rest of their lives. So I showed you acute continuation and maintenance treatment. That's about 6 months. Saying, we're going to reevaluate in 6 months the risks versus benefits of staying on versus coming off. And if somebody has a recurrent form of the illness, I'm probably going to continue them longer. If you can, leverage your medical assistants and nurses for between session check-ins. About 40% of people don't even get their prescription filled or picked up at the pharmacy. So having your office staff contact the patients to make sure that they've filled their prescription, ask if they're tolerating it early, they can share that information with you, and you can contact the patient just for a 5-minute call to help alleviate any concerns or problems they're having with the medicine. I think you're going to hear this from the other speakers today, but engaging family supports and considering a dyadic approach to treatment is really critical, because if the patient is not on board with treatment planning, especially for older adults, or they disagree with the diagnosis, treatment and outcomes may be sabotaged. Finally, and I've said this earlier, assure obstructive sleep apnea and diabetes are well controlled, because it's difficult to get people to remission, to get their depression to remission, if these other conditions are not adequately controlled. So I'm nearing the end of my talk, but I want to share with you an algorithm for late life depression treatment adequacy and access. So this is data that's based on my group's work. If you prescribe an SSRI under high quality circumstances, where patients are taking it every day, they're getting adequate support, you can get about 50% of people well. For the other 50% who don't get well, you prescribe an SNRI, about 47% of people can get well. For those who don't get well, we can augment with aripiprazole and get about 29% of people well. And then we can use other neurointerventional treatments like TMS, transcranial magnetic stimulation, ketamine, or S-ketamine. A primary care doctor can prescribe an SSRI or an SNRI, or can augment with something like aripiprazole or bupropion. We can also use collaborative care for more difficult to treat patients with the assistance of a supervising psychiatrist. And certainly we need specialty mental health care for the delivery of TMS, ketamine, and S-ketamine. So let's walk through this. If we have 100 people, we can get 50 people well in primary care with an SSRI. So we're left with 50 people. We can get 24 people well with an SNRI. So now we have 26 people who are not well. We can get about 8 people well with aripiprazole augmentation. That leaves us to 18, and we can get about 4 people well with ketamine or TMS. Well, and we've probably got a couple more well just by prescribing psychotherapy earlier on in treatment. So we can probably get about 90% of people well. Well, what about the other 10% of difficult to treat depression in late life? I think we need to revisit and clarify the diagnosis and reevaluate cognitive status, because both of these are intersect, and both can be causes of treatment non-response. We need to reevaluate social determinants of health, adequacy of supports and the residential situation to make sure it's safe, the stability of comorbid medical problems and loneliness. We need to reevaluate cognitive status. This is not a typo. I just can't reiterate how important this is in older adults who are not getting well from their depression, that it may be a prodromal or early stages of a neurodegenerative or dementing illness. And then you could refer to psychiatry with the consultation question, Please evaluate for difficult to treat depression and possible use of ECT. Things to know about ECT. It should be considered in older adults who are treatment resistant. I'm sorry, I'm using that term again, but they haven't responded to pharmacotherapy, or they're unable to tolerate antidepressant medicines, or they're urgently ill. ECT is safe, even in frail older adults with multiple medical comorbidities, including cardiac, pulmonary, and neurological disease. And it can be life-saving in urgently ill older patients who are suicidal or catatonic. So I want to share with you the results of phase 1 of the PRIDE study, which was use of unilateral ultra-brief ECT in late life depression. I'm just going to draw your attention to the left panel here. So of the remitters, over 60% remit. These are very sick people who were inpatient, but they got about 60% remitted, close to 70% responded. And let's look at the right panel here. This is the speed of remission among remitted patients. Patients were also receiving venlafaxine in addition to the ECT. So over the course of 2 weeks, there are 3 sessions of ECT per week. This is the cumulative percent of people who remitted. About 45% of the people remitted. At the end of 3 weeks, 9 ECT sessions, over 70% had remitted. Really amazing outcomes of people who have tried and not responded to so many different treatments, and most of these people were in the hospital. The neurocognitive effects of ECT is real. It is mostly temporary. And another study that came out of the PRIDE project showed that they are time limited and was really quite modest. We also need to remember that depression is toxic for the brain and memory. And most people, when you explain this to them and they understand that there may be some anterograde memory problems, but most of the time memory returns to normal, they think that the benefits outweigh the risks. I want to share with you some Arizona difficult to treat resources to help you care for your patients. Here at Banner University Medical Center, we have the Center for Interventional Psychiatry and Neurotherapeutics, where we can do comprehensive evaluations of patients with difficult to treat depression. We offer TMS, ECT, S-ketamine, and IV ketamine. And we also have a new clinical trial using a novel mechanism augmentation agent for people 18 to 74. I have the QR code here if people are interested in learning more information. This is a really nice opportunity for many people in the community who are looking to participate in a clinical trial and try something novel for their depression. So my last slide is take a really good history, get really good at first and second line pharmacotherapy options, understand the impact cognitive changes, just changes in the aging human has on depression outcomes, and implement what you learned today from Dr. Anderson, Dr. Tariot, Dr. Stahl, and Dr. Fain about identifying and managing depression, caregiver burden, and frailty, and know when to refer and how to refer. With that, I want to thank you again for choosing to spend your Saturday with us. So there's a question here, does aripiprazole augmentation mean adding it to an SSRI or SNRI? Yes, it does. So for people who have had some response to an SSRI or SNRI, there's evidence that both augmentation with bupropion or Wellbutrin and Abilify or aripiprazole can bring about further improvement. Aripiprazole and Wellbutrin both have been shown to be safe with limited metabolic or movement effects on movement. There is some evidence that actually bupropion or Wellbutrin can worsen the risk of falls compared to lack of this risk when augmenting with Abilify. And we published this paper in the New England Journal of Medicine. I'm the last author, if you want to Google that, earlier this year in 2023. There's more questions that are coming through, but I want to keep us on time, and I promise you that we can address some of these questions during the Ask the Expert session later this morning. Okay, so it's really a pleasure to introduce my friend and colleague, Dr. Sarah Stahl, who I've known for many years. She is a developmental psychologist and associate professor of psychiatry and clinical and translational sciences at the University of Pittsburgh. She is core faculty at the University of Pittsburgh Center for Behavioral Health, Media, and Technology. and the Center for Sleep and Circadian Science. Her areas of expertise include geriatric mental health, circadian rhythms, family caregiving, grief and bereavement, behavioral intervention development, and technology and aging. And her work has focused on circadian disruption of health behaviors in late life depression, with an emphasis on developing and testing digital health interventions that stabilize the 24-hour rhythm of sleep, meals, and activity. She's particularly interested in promoting the health and well-being of older adults who are at risk for depression following stressful life events like family caregiving and spousal bereavement. I could go on and on because Dr. Stahl is very accomplished, but I want to give her plenty of time to speak, so I will turn things over to her.
All right, so today I'm going to talk about preventing and managing caregiver burnout. My work is funded in part by the NIMH, and I have no conflicts to disclose. So today I have 3 learning objectives. So first we're going to talk a little bit about the emotional and physical health effects of family caregiving in late life. And then we'll move on to talking about self-care strategies for older caregivers, because it is widely known that older caregivers have a very difficult time taking care of themselves. So we'll talk about some self-care strategies. And then finally, we'll talk about what happens when caregiving ends. And we'll talk about bereavement after caregiving and whether the different types of caregiving that older adults are engaged in late life impacts bereavement outcomes. Okay, so the first section is the health effects of family caregiving. So the question I want you to think about are what are the emotional and physical effects of caregiving in late life? So I first really want to review some family caregiving statistics so that you can just see how ubiquitous family caregiving is and will continue to be in the United States. So currently, oh, where did my screen go? Currently, 1 in 5 adults, which is about 53 million people in the United States, are providing unpaid care, that's a key word here, unpaid, to a family member with health or functional needs. So most people cannot afford to pay for a formal caregiver. So most family caregiving in the United States is unpaid care. About 26% of family caregivers have difficulty coordinating their care, and another 25% are caring for someone with Alzheimer's disease or a related dementia. And both of those statistics, even within the last 5 years, have increased. So in the last 5 years, it went from 20 to 25% of people. So more people are caring for someone with Alzheimer's disease and more people are having difficulty coordinating care. In addition, about 23% say that caregiving has made their own health worse. So caregivers really have a difficult time managing time and finding meaningful time to take care of themselves. So we'll talk about that in the second section. Family caregiving spans across all generations, including baby boomers, Gen X, Gen Z, millennials, and the silent generation. And finally, about 60% of family caregivers are also working. They're working full-time jobs. They're also trying to manage these caregiving responsibilities. So they're very stressed. So what does the typical caregiver look like in late life? So typical caregivers, they tend to be women, but they're also either middle-aged adult children who are caring for their older parents, or their older spouses who are caring for their spouse or life partner with functional limitations. So I want to talk a little bit about the economic impact of caregiving. Why my screen keeps disappearing. It just went black for everybody, right?
No, we can see it, Sarah.
Really?
Yeah.
Okay. Monitor just like died. Okay. If you can still see it, I'll keep talking. Okay.
Sure.
Okay. So the economic impact of caregiving. So let's see, the value of services provided by caregivers has steadily increased over the last decade. So currently, with an estimated economic value of about $600 billion in 2023, which is up from $470 billion just 10 years ago. So remember that 60% of caregivers are also working full-time jobs. Well, it's estimated that the economic cost to U.S. businesses for lost productivity due to caregiving is it's estimated between $17 and $30 billion annually. So as caregivers juggle their responsibilities, they often face significant challenges in balancing their work and balancing their caregiving duties. And so this leads to lost wages, missed career opportunities, and job loss. Family caregivers lose over $500 billion in wages annually. And this is especially true for women, who comprise the majority of caregivers, about 61%. So these women are disproportionately affected by the income disparities associated with caregiving. And I said in the previous slide that most caregiving is unpaid. So paid caregivers are just simply too expensive for most families. And the home care workforce shortage means that they're just not available to families who can afford them. And so in fact, the cost of long-term care services in the US is about $20,000 per year for adult day health care to about $110,000 per year for a private room in a nursing home. So there's a lot of out-of-pocket expenses for older caregivers. So informal caregivers spend about $7,000 on average per year on things like medical supplies, home improvements, and rent, among other things. Okay, so just checking that you can see that this next slide says caregiving tasks. All right,
Yeah, we're in good shape.
Okay, all right. So caregivers are mainly providing support with ADLs and IADLs in late life. So both ADLs and IADLs refer to these key life tasks that need to be accomplished daily. So ADLs, or activities of daily living, these are more basic tasks that are essential to independent living. So these are things like walking, feeding, using the restroom, moving around your house, transferring from from your bed to a chair, bathing, dressing. IADLs, or instrumental activities of daily living, are more complex tasks that are still a necessary part of everyday life. And so there's a lot of different IADLs. This is just a few of them. So things like managing finances, managing transportation, grocery shopping and meal preparation, managing medications, household tasks and chores. So older adults begin to lose their independence when they're no longer able to complete ADLs and IADLs on their own. So on average, older caregivers, are performing about 2 ADLs, most commonly getting in and out of beds and chairs, and helping with walking around their house. They also perform about 4 IADLs, most commonly things like transportation, grocery shopping and meal preparation, and a lot of housework. Most caregivers report that they don't have a choice about these caregiving tasks, and that this lack of choice is self-imposed. Some feel that these tasks are their personal responsibility because no one else can do it, or because insurance will not pay for a professional caregiver. A smaller percentage of caregivers report that they feel pressured to perform these tasks, either by the care recipient themselves or by another family member. So to just really put into context how much time older caregivers are spending on ADLs and IADLs, this figure shows the number of hours dedicated to caregiving by the age of the family caregiver. So on the x-axis, we see the average number of hours of care provided each week, ranging from 0 up to 40 hours. And then on the y-axis, we see the age of the caregiver. And so we can see this relationship that with older age, older adults are spending more time per week providing care to a care recipient. And if you look at the oldest group, those that are 75 years of age and older, look how much time per week they're spending on caregiving, which is likely their older spouse, right? So they're spending almost 35 hours per week providing care to one another. I want to talk a little bit about caregiver gender and the types of care tasks that older caregivers are engaged. So approximately, I said before, about 60% of all older caregivers are female, and they may spend as much time as 50% more time than males providing care. So it has been changing in the last several years. Males are engaging in more caregiving tasks than in the past, but females still shoulder the major burden of care. So they're providing about 22 hours of caregiving per week compared to males who are about 17 hours per week. But in that oldest group, the 75 years and older, those men and women are spending equal amount of time providing care to one another, likely because they are both likely physically declining because of their age, and so they're each providing care to one another. Interestingly, let's see, about 36% of those female caregivers are handling the most difficult caregiving tasks like bathing, toileting, dressing, compared to about 24% of males. The males are more likely to help with things like finances, arrangement of care, and other less burdensome tasks. So we have seen in the literature for the last several years that there are these gender differences in caregiving in late life. So most of the early research on the health effects of caregiving in late life focused on the negative health effects of spousal caregiving. So this was a seminal paper published in 1999 by Richard Schultz and Scott Beach here at the University of Pittsburgh, showing that caregiving is a risk factor for mortality among older spouses. So prior to this paper coming out in 1999, there was a strong consensus that caring for an elderly individual with disability is very burdensome and stressful to many family members and contributes to psychiatric morbidity. Researchers also suggested that the combination of prolonged distress and the physical demands of caregiving may compromise caregivers' physiological functioning and increase their risk for many different physical health problems leading to mortality. So in this paper, they looked at 4-year mortality based on differing levels of caregiving among caregivers and compared them to a non-caregiving control group. And so what they found, excuse me, was that being a caregiver was an independent risk factor for mortality, so they were more likely to die compared to those non-caregiving controls, but it was only among the caregivers who reported experiencing mental or emotional strain. So those who were providing care and reporting this caregiver strain, they had mortality risks that were about 60% higher than the non-caregiving controls. So it's not necessarily that, engaging in caregiving is going to increase your risk for mortality. It's really among those caregivers who are really distressed and report mental or emotional strain. And then more recent works after 1999 focused more on the positive aspects of family caregiving and how caregivers find benefits in their roles and activities. So many family caregivers, over 80%, report a lot of positive experiences, including a sense of giving back to someone who has cared for them in the past, the satisfaction of knowing that their loved one is getting excellent, great care. They do find or experience a sense of personal growth during the caregiving experience or social role of being a caregiver, and finding increased meaning and purpose in one's life. And what has been replicated in many studies is that caregivers who perceive more positive benefits from caregiving report lower levels of depression, lower levels of anxiety and distress, which is protective in late life. So in the second section, we're going to talk a little bit about self-care strategies for family caregivers, and it's really difficult, like I said, for them to find meaningful time to spend time on themselves. So how can we help them optimize their health and well-being? So taking care of oneself is one of the most important things that caregivers can do, but they often find that they can't find the time to do so, or they feel guilty for neglecting their care recipient, and so they tend to neglect their own health. So it's very common for them to miss doctor's appointments, skip meals, have disrupted sleep, not engage in exercise, simply because they're feeling too stressed or overwhelmed with their caregiving responsibilities. So some very common signs of caregiver distress include not getting enough sleep. So sleep disruptions are very common. Difficulty falling asleep, having a lot of nighttime disruptions, and then just not getting up at the time that they would like to get up at in the morning. So sleep disruption is a common sign of caregiver distress. Gaining or losing weight, losing interest in activities that they used to enjoy, or having frequent headaches or other physical health problems. So I'm involved in a couple caregiving studies here at Pitt, and these are some self-care tips from caregivers themselves after talking to several caregivers. And so actually these are self-care tips that, is good. These are good for everybody, but some things that caregivers themselves want to try to focus on themselves. The top one is to find a way to exercise. So the most common is walking. They love walking outside, especially if they have a pet and can get that pet or that dog outside. They really want to try to find a way to exercise. And in another study that I'm involved with, we're really trying to get people to find exercise time in the morning. I'll talk about that in the next slide. So exercise, they know exercise is really important to them. Most people, especially if they're experiencing that mental or emotional strain, remember, which is a risk factor for mortality, they're also experiencing some sleep disruptions. So they really want to try to focus on their sleep. So being more active during the day and trying to get good sleep at night. The third thing that they want to do, but they say is harder to do than sleep and activity, is to socialize with their friends and family. They know that this is important, they want to do it, but they themselves have difficulty scheduling this and wish that other people would call them and be the ones to initiate social activity with them. Because if they have any time to themselves, they're going to try to exercise or do restful things before bed. It's really hard for them to reach out to others and socialize. So if you know a caregiver, give them a call today. Spend some time with them. They really, really, really like talking to other caregivers about their experiences caregiving and their stresses, and really want to feel validation. So they really would encourage all other caregivers to join a caregiver support group. Almost all of the caregivers in any of our caregiver studies are involved in caregiving support groups, and they really appreciate the support and the ability to talk to one another about what they're feeling. And then a few of those caregivers have recognized that they really like talking to other people about their day and what they're going through. And so several have recognized that they may need to seek professional help from a counselor or therapist. So all these self-care tips, right, they're good for everybody, right? Get your activity, sleep, socialize, but what else can we do to try to help caregivers engage in self-care? So two things that I've learned that seem to work in our studies is, one, try to include the care recipient in exercise. So this was from someone that I talked to a couple weeks ago, and she started including her husband, who's her care recipient, who has dementia, in her morning routine. Her morning routine is that she just wanted to stretch a little bit and go outside and get some morning sun. And so she actually liked including her husband in that activity for two reasons. One, it got him out of his chair, because she said he would just kind of sit in his chair all day. So it got him out of that chair doing something. And it felt like they were doing something together as a couple. So she felt like she was able to reconnect with her partner by incorporating him into her exercise activity. So if there's any way we can include the care recipient, that seems to help encourage behavior change and maintenance of self-care over time. The second strategy is allowing caregivers the opportunity to vent. So most caregivers want to feel validated and heard and need a space to talk. Whether that space is a support group, a therapist, a group exercise class, they really just want to talk to other caregivers about what they're experiencing throughout the day. So those two, maybe some new strategies for how we can try to encourage caregivers to take better care of themselves. So I've talked a little bit about some of the studies that I'm involved with that focus on caregiving in late life. So just very briefly, so some emerging strategies that may optimize caregivers' health and well-being actually focus on strengthening circadian rhythms. And so we know that caregivers are likely to have a very low level of activity. It tends to be irregular, and they have these sleep disruptions at night. So in a couple studies, we're trying to focus on helping those caregivers be more active, maybe including their care recipients, and maybe doing it in the morning, because if we can get people to just get going in the morning, it may help them be active throughout the rest of the day. They may sleep better at night. And so focusing on morning activity may reduce caregiver distress like depression and anxiety. But that's one ongoing trial. A second trial is developing an app so that caregivers can see objectively what their activity and sleep patterns look like from one day to the next. So that's what these figures are on the left. So some of these lines just show like activity counts throughout the day, so that we can really try to help caregivers, be active at the same time every day, sleep at the same time every day, and help them just become more mindful of their 24-hour pattern of sleep and activity. And so this is also an ongoing study, but we have noticed that caregivers have been able to increase their sleep drive because they're more active throughout the day and they have a better time falling asleep and staying asleep throughout the night. So something like this may promote a strong circadian rhythm and may help caregivers have more positive health outcomes while caregiving. So in the final section, I want to talk a little bit about what happens when caregiving ends, so bereavement after caregiving. I want to think about answering the question, does the type of caregiving matter in terms of bereavement outcomes? So in short, the answer is yes. Caregiving and the circumstances surrounding death impact bereavement outcomes. So very briefly, why should we study bereavement outcomes after caregiving? Because it does a lot of different things to your body. There are a lot of different ailments and reactions that occur after experiencing the death of a loved one. So what exactly does bereavement do to your body? So there are a lot of emotional reactions that are common, like feelings of sadness, hopelessness, anger. Cognitive difficulties are very common, like difficulty making decisions and concentrating. Memory problems are common. In older adults, physical ailments during the bereavement process are also very common. So we commonly hear about fatigue, exhaustion, headaches, high blood pressure. There's a lot of behavioral changes. So a lot of sleep problems, difficulty falling asleep, staying asleep. There's changes with meal patterns, eating too much or eating too little. Also having an irregular activity pattern, being too active or very sedentary. There's also immune changes. So a weakened immune system is very common among the bereaved, making illness and infection more likely. Increases in inflammatory cytokines or chronic inflammation is common among the bereaved. And then finally, circadian rhythm changes are also common among the bereaved. So changes in this 24-hour rhythm of when they're active and when they're asleep, which may put them at risk for a lot of other physical and emotional health problems in the long run. So I want to focus on the effects of two very common types of caregiving in late life, cancer caregiving and dementia caregiving. And so I have a second line of research that really focuses on bereavement and bereavement outcomes. So I'm going to talk, so that's why I picked cancer caregiving and dementia caregiving, because these are the two most common types that I see in my bereaved participants. So we really are interested in whether the type of caregiving before the death impacts adjustment or bereavement outcomes after the death. So let's talk a little bit about bereavement after cancer caregiving. So the bereavement literature suggests that loss due to cancer may be particularly challenging for surviving spouses or partners because of a very difficult and unique end-of-life experience, such as an exhausting caregiving situation, witnessing and managing depression symptoms in the care recipient, and being socially isolated while providing daily care to the dying care recipient. So consequently, persons bereaved from cancer caregiving compared to those who were bereaved by other causes of death are hypothesized to be more susceptible to a variety of negative health outcomes, including depression, anxiety, complicated or maladaptive grief, and loneliness. So to date, few studies have compared adjustment outcomes over time among those spouses or life partners who died to cancer versus other causes of death. So there's actually a second body of literature that suggests that, maybe cancer caregivers have better bereavement outcomes because of these two concepts. They're prepared for the death. Most cancer death, most people are prepared, and it's an expected death, right? So in many other studies, if you're prepared for the death, you have better bereavement outcomes. So it's possible that cancer caregivers have better outcomes because they are prepared for the death, and they are likely to experience anticipatory grief. So being able to grieve prior to the death, that has also been shown to support a more positive grief journey. So let's look at some bereavement outcomes by cancer caregiving. So bereavement outcomes by the cause of death. So in the top figure, we have depression outcomes, and in the bottom figure, we have grief outcomes. So compared to those who were bereaved by other causes of death, those that were cancer caregivers were more likely to have higher depression symptom burden and more maladaptive grief. So the cancer caregivers are the bolded line in each of those figures. Depression's at the top, grief is at the bottom. On the x-axis is time since loss. So we can see in both of those figures that the bolded line, which are the cancer caregivers, have more depression than the non-cancer group and more maladaptive grief than the non-cancer group. And those levels sustain over time. So they're more depressed and have more maladaptive grief. So cancer caregiving is interesting though, because the death is expected. And so in many other bodies of literature, if the death is expected, people are more likely to have, more positive outcomes. So in this study, several researchers looked at whether death expectedness may lessen depression and grief symptoms in cancer caregivers. So again, in both of these figures, I actually switched this time, sorry. So grief is at the top, depression is at the bottom. So the grief bereaved by cancer is in bold. Those that expected the death are the solid line, and those that did not expect the death are the dotted line. And actually those two lines are not significantly different from each other. So whether or not the death is expected in the context of cancer doesn't really matter. The group with the lowest depression and grief scores, which in both figures is that solid line at the bottom, were the expected non-cancer deaths. And so that's what we see in other bodies of research, that if the death is expected, less depression, less maladaptive grief. But in cancer, that doesn't seem to have a protective effect. Why not? So when someone is diagnosed with cancer, the time during and following treatment is often described in terms of a battle, which is a description not typically used in other terminal diseases like congestive heart failure, or even Alzheimer's disease. So this struggle or battle is rarely borne by the patient alone, but also by family members, particularly spouses. So by the time that the battle is lost, it's taken its toll on survivors. So it doesn't matter that the death is expected in the context of cancer. People feel like they lost this battle, and that seems to be impacting depression and grief scores in the cancer bereaved. So let's switch a little bit and talk about another common type of caregiving in late life, dementia caregiving. So with bereavement after dementia caregiving, dementia caregiving is an extended period of caregiving, often for years. And so the death of that family member with dementia often provides a sense of relief to the caregivers because their caregiving role has ended and their loved one is no longer suffering. So these feelings of relief are very common, and caregivers will tell you that these feelings it's an uncomfortable feeling to feel relieved. They don't really tell other people that they feel relieved that their loved one has died, but these feelings of relief are very common. So in some of my own work, we were interested in whether caregiver relief, because it is such a common emotional reaction after dementia caregiving, we wondered if this positive emotional reaction was associated with adjustment post-loss. So it actually matters on the type of caregiving, it depends on the stage of dementia. So we first looked at what predicts feelings of caregiver relief. It's very common, but what predicts these feelings? And so that is what depends on the stage of dementia. So in the top box, we have people who are caring for someone with mild to moderate dementia. And in the bottom box, we have those caregivers that were caring for someone with severe dementia. So care recipient suffering was the strongest predictor of relief in caregivers of mid to moderate stage dementia. So knowing that their care recipient or loved one was no longer suffering, that was the strongest predictor of experiencing feelings of caregiver relief. But that was different among those caregivers who are caring for someone with severe dementia. So among those caregivers, being prepared for the death was the strongest predictor of caregiver relief. And so it does seem likely that these caregivers would be more prepared because their care recipients were in the very late stages of Alzheimer's disease, had very high levels of impairment, and were likely very prepared for the death for several years. And so preparedness to death, which we see in many, many other studies, preparedness for death promotes bereavement adjustment. So then we looked at whether caregiver relief was associated with adjustment. And so what we found was that caregiver relief was strongly associated with fewer symptoms of complicated grief, which is a maladaptive grief response.
Dr. Stahl, we have about 2 more minutes for you.
Okay, yep. Okay, so caregiver relief was associated with fewer symptoms of complicated grief. So maybe a protective factor against significant distress and impairment in caregivers. And so this finding supports this relief model of bereavement, showing that positive feelings of relief, which is common after dementia caregiving, may allow for better adjustment to the care recipient's death. And so from a clinical perspective, this suggests that we need to reassure caregivers that feelings of relief are very common and they're actually warranted following their role as a family caregiver. So in sum, I hope that I've been able to demonstrate that caregiving has both positive and negative effects on health. Self-care is very difficult for caregivers. They recognize this, but they have a really difficult time finding meaningful time to take care of themselves. But we know it's important for their health and well-being. And then finally, individuals' caregiving experience does impact their adjustment to bereavement. Thank you very much.
That was great, Dr. Stahl. Thank you. That was a wonderful overview of caregiver burden and bereavement and your own research program. That was super. In the interest of time, I want us to keep moving ahead. There are some questions that are coming up for Dr. Stahl, but we will address these during the Ask the Expert question. I don't think Dr. Stahl will still be on, but if we need to, we will reach out to her. And there are other geriatric and gerontology experts who will be available at the Ask the Expert. So it's now an honor and a privilege to introduce another friend of mine. Dr. Alan Anderson is a board-certified geriatric psychiatrist who has worked in the field of Alzheimer's disease and related dementias for decades, performing evaluation and treatment of patients and, consistent with Dr. Stahl's talk, their family caregivers. He has an international reputation. He's the past president of the American Association for Geriatric Psychiatry. And in 2014, he received the American Association for Geriatric Psychiatry Clinician of the Year Award. He left Maryland about 4 years ago, where he was at Johns Hopkins School of Medicine and is the medical director of the Toole Family Memory Center and the Banner Alzheimer's Institute here in Tucson. And he leads a dedicated staff of dementia care specialists providing clinical care to patients and families and leading clinical trials and other research in Alzheimer's disease treatment and prevention. I could go on, as I could with all of our speakers, citing their accomplishments and praising them, but I want to give Dr. Anderson plenty of time for his talk. So I'll turn things over to him.
Thank you very much, Jordan. Appreciate being here. I will say that I think this is a great program, and I thank both Dr. Karp and also Jamie Manser and other staff, Department of Psychiatry, for setting this up. I'm glad to be here. Talking actually from my office at Banner Alzheimer's Institute. Just quickly, we are an institute with 2 other sites in Phoenix that really support a very comprehensive care of a patient with dementia, but also great care delivered for family and community services to caregivers. So let me start my slideshow. I will be discussing some off-label use. As many of you know, we don't have many medications that are approved for managing agitated behaviors in patients with dementia. And just a brief about how this affects folks in our clinics and folks you treat. First of all, it's seen in a large majority of dementia patients, especially more so in people who are in long-term care. And it can lead to more rapid decline, also leading cause of caregiver burnout and institutionalization of their patient, and also more costly with things like ED visits that may be unnecessary and psychiatric hospitalization. So we really do want to pay attention to this syndrome of agitation and dementia. This is two advertisements from medical journals in the 1960s when they were advertising for antipsychotics, in this case chlorpromazine, to manage patients with senile agitation. We now rarely use medicines like this. I don't know whether Thorazine is still used other than in the OR for hiccups. So what happens all too often is staff or individuals, it could be family members, that speak down to their dementia patients. They say things that are often infantilizing. They tell people what to do, what not to do. They really follow some of their own feelings of how they should discuss things with the family member suffering from dementia. And what we want to see, of course, is something different. We want to see individuals who really get on the same level as the patient, engage the patient, and create a happier and more joyful interaction. On this slide, you'll see 11 neuropsychiatric symptoms of dementia. These are 11 out of 12 from the neuropsychiatric inventory. The 12th really doesn't fit this because it's eating behavior. You may see more of that with things like frontotemporal dementia. But it's also been called these have also been called the behavioral and psychological symptoms of dementia, or BPSD. You know, it's important that we think about how we categorize and understand these behaviors, right? And Jessica and Mansfield originally sort of talked about this as often as an unmet need. And so they may represent the way that the individual with dementia communicates an unmet need, especially those that are more advanced in dementia and truly cannot do that through verbal means. And we sometimes interpret that these are volitional, but typically they're more a manifestation of the dementia and how the dementia affects their view of what's going on around them. You know, there may be triggers, and it's important to identify triggers because once we know a trigger, we can then anticipate when these behaviors might occur. We can change things in the environment or change things to allow the trigger to be managed and therefore hopefully even prevent some of these behaviors. But just briefly on non-pharmacologic approaches, we do a lot of training of our family caregivers, some of our professional caregivers that bring patients in, but we train them on different communications techniques. You can see some of these. I can't tell you how many times in the past I've seen even what I thought would be skilled people speak from behind the patient, from the side of the patient, approach the patient and touch him from behind. You really want to make yourself available both visually and auditorily to patients. Remember, as we get older, we rely more on facial cues to communication. And so it's very important to meet them where they are. And it's also in terms of the level. If you were to go into a room and speak to a patient and they're in bed, you know, kneel down or bring up a chair, put yourself on their level. Don't speak down to them. Don't over-explain, validate concerns and feelings. I will tell you, I myself, over my decades of working in this field, I've gotten out of some tight situations by first taking a deep breath, because I figured that the first thing I might say was incorrect, and then thinking about how I might validate the person's feeling. And I will tell you that that can get you out of some tough and tight issues, because we're humans, they're humans. Human beings want to know that others understand and appreciate what they're feeling. It's very important to do some of that. We always want to tell our caregivers, look, this isn't your husband from the last 50 years. This is your husband now with a disease. This is your wife now with the disease. That disease is causing some of these symptoms. And we also do some supportive psychotherapy for caregivers. We know that caregiving of dementia patients leads to significant levels of anxiety and depression, and so we want to make sure we manage that in the caregiver. Exercise both for the patient and the caregiver are good, and sometimes, of course, we need respite care. So I worked for a number of years at a place called the Copper Ridge Institute, associated with Johns Hopkins in Maryland. And at the Copper Ridge Institute, years ago, before I started there, they came up with these 5 Ds: describe, decode, devise, do, and determine. I was kind of laughed about the 4th one because I thought if you took all the time to describe what was going on, decode and make it have some understanding of what might be causing it, then devise a plan, my gosh, of course you're going to do it, right? And so when DICE came out, and this came out in an article that was in JAGS, they made the acronym 4 and simple, so 4 points: describe. And by the way, description should be what maybe was occurring before the agitated or aggressive behavior, what happened as a part of that behavior, and what happened following it, what interventions were done, and how successful or unsuccessful were they. And so we describe, then we investigate. We investigate to say, well, what might be going on here? Now, for example, a simple thing might be that the investigation leads you to know that there's a patient who's having frequent urination, more incontinent, foul-smelling urine, and maybe a mild elevation in temperature. Oh, okay, they got a UTI. That's an easy one, right? Because we can devise the plan or create the plan to fix the UTI with antibiotics, and then evaluate and hopefully watch if those behaviors over days diminish. And if we know something works, the other important thing is broadcast it. All the members of the team in an institution, for example, need to know, hey, this worked, let's keep trying this. By the way, this is an interesting concept because it really is a scientific method. I mean, for hundreds, thousands of years, we've looked at things in our environment or things in nature and said, well, that's interesting. I wonder how that came to be. And so we formed hypotheses, tested the hypothesis, and then moved science ahead. And this can be taught to every CNA, every nurse, every person, social workers and staff that work in long-term care. And it can really be helpful in preventing a lot of problems with behaviors. And this is actually from the DICE article. I'll leave this up for a minute. I'm not going to read all of this. But the authors, Helen Kales, Laura Gittman, and Costas Laketsos, put this in JAGS in 2014. So please look that article up. I send this article to any nursing home or memory care assisted living. When I get patients and it's clear to me that the problem isn't that they need to be on an antipsychotic, the problem is the staff need to be educated on how to manage these. And they did a study on DICE implementation. And as you might expect, the training of individuals, and these were family caregivers, really gave them an appreciation of how to do things differently. They felt that they were more adequately equipped to deal with the behavior. So, but by the way, we have a great service that we provide now through Banner Alzheimer's. It's a podcast. It's called Dementia Untangled. You can get it on any place you get podcasts. And one of the ones that I did, and it's done by many of our experts at our 3 clinics, 2 in Phoenix, 1 here that I'm at in Tucson. And we also use external experts as well. But I was tasked to do it on sundowning, and I came up with this acronym you could use for the patients with agitation as well, right? So P of Pulse D, P stands for pain or physical distress. Often, if you really play detective and look at people and examine them and see what's going on, you can identify that pain may be the cause. Physical distress, what about significant constipation? You need to really check to make sure our residents are having bowel movements or other issues that cause physical distress, like someone who can't communicate but walking around a unit with a Depends that's full of urine and is very uncomfortable. U stands for UTI, but I will say that that's because that's what we commonly often see as a cause of the behavioral change in dementia patients. However, I would also add any other infection, any other significant medical problems that causes an acute change in the physiology of the patient should be identified and managed. L is for light, and this is probably more so for institutions, because if you go back decades, institutions were really not a pleasant place. They were dark, cinder block walls, and you didn't have much external light. People didn't get outside for light. And light therapy itself can be helpful. I can mention that later. S for sleep, sleep for the patient. Patients with dementia have altered sleep-wake cycles, and since they don't maybe get the sleep they need, which includes some restorative sleep, they're likely to be more confused during the day and more likely to then engage in some agitated behaviors, but also stress. Caregiver stress, when it's not attended to and dealt with, is often the cause of a problem where the patient becomes agitated. And these are caregivers. Look, people have been married to someone for 50 years, and they've had 50 years of communicating in a certain way. And now suddenly things are changing, and they don't change their communication style, and things can get pretty ugly. Environment, or E, that's important. Too stimulating an environment can cause some agitation. For example, we have a lot of sandwich families where an adult child is working, but taking care of kids, taking care of mom or dad with dementia, and they may even be working, and people come home and the TV goes on and music goes on, and there's noise, and the environment is too chaotic. And lastly, D, effects on medications and supplements. I can't stress this enough. You want to take a list of the medications your patients are on, and you want to look especially at anticholinergic load. You also want to examine whether or not they're on medications that can cause sedation. And also think about asking about prior psychiatric illness, because sometimes that's missed. And you may have a bipolar patient who's now having some euphoria, and it really needs to be addressed as part of bipolar, not part of the dementia. By the way, the reference down below, just from last month, is a great reference for primary care folks, because it talks about some of the ethical aspects of deep prescribing. And a lot of clinicians are concerned about deep prescribing, but really it's something as we work with geriatric populations, we have to do. I saw a patient this week. She was on hydroxyzine 3 times a day, furosemide, which she needed to be on, but has anticholinergic effect, and then some narcotics. So we need to look at what we can deep prescribe in patients like that. Typical behavior triggers are on here. You can look at this, but I will just tell you, for the last bullet is, in my opinion, the most important bullet, both for family caregivers and professional caregivers that are working with dementia patients. Communication, communication, communication. I can't stress that enough. And at BAI, at all our sites, we do a lot of work in talking to the family members or professional caregivers about how they really have to adjust differently in communication. I mentioned a great book written by an occupational therapist, Creating Moments of Joy, and it is by Jolene Brackey, and it is full of really good tips and hints about how to change communication styles to avoid more agitation in the patient with dementia. I'm going to go over the Harvard algorithm, but there's been 3 kind of recent algorithms, and some people like algorithms, some don't. All of these do have some treatments that have some scientific benefit for the suggestions, but they all have some where the scientific evidence is really kind of minor or not very significant. And so there's still a lot of art and a lot of experience that you bring into managing behaviors in terms of treatments with pharmacologic agents. I'm going to go through this quickly because you can get it from the reference below. But Harvard put out, I think, what is probably one of the better ones. And you can see, first thing is look at anticholinergic load and manage pain control. I've been a big proponent of arthritis strength Tylenol twice a day. I can go up to 2 of the 650 milligram tablets twice a day. I'm a big proponent of trying to fix pain before it gets not fixable, right? So I don't like PRN orders because some nurses might say, oh, the patient doesn't have too much pain. I'll just wait and see what happens. And others will give it right away. And so optimizing pain is really managing pain and preventing it from escalating. Sleep medication may be needed. Trazodone is a common one. But donepezil and memantine, and donepezil could also be rivastigmine or galantamine. These can actually have some benefit in behaviors. I will say, especially cholinergic medications like the donepezil, rivastigmine, and galantamine in dementia with Lewy bodies and Parkinson's disease dementia, in terms of really reducing some of the behaviors. Second generation antipsychotics, we know to use them. We also know that there's problems in using these too often in the nursing home setting. The prazosin situation, a couple of smaller studies showed some benefit. Many of us don't tend to use this too often. You have to worry about orthostatic hypotension and drops in blood pressure. But then on occasions, perhaps use of carbamazepine, but keep the dose lower. They have different algorithms for something that's urgent, where they may go right away to an atypical antipsychotic and or ECT. And then in emergent, this is when people are ready to either hurt themselves or hurt somebody else. You may decide to call 911 and have them go to the ER, but you could try intramuscular injection of olanzapine. Originally, the Harvard folks thought that IM or piprazole would be a reasonable choice, but that is no longer available. And then you can go to the old tried and true of IM Haldol and IM benzos used in some cases, but you have to be careful about sedation falls. And benzos do decrease cognitive functioning as well. Pimavanserin. So this is actually an article that was published with the first author being Dr. Tariot, you'll hear from soon, showing that pimavanserin can have a benefit in reducing psychotic symptoms in patients with other dementias. Again, it's a medication that's approved for Parkinson's disease psychosis. By the way, I will tell you, if you're doing your chart, I always put down, if I have a dementia patient due to Parkinson's disease dementia, and Parkinson's disease separately, because it's technically only FDA approved for Parkinson's disease psychosis. And while this did show some positive results when the FDA reviewed the data, they didn't think it was strong enough to give the approval for pimavanserin to be used in patients with other types of dementia. Because I want to mention brexpiprazole, because you may know this is the kind of the first larger kind of medication to use. I say that because we have other things like the combination of quinidine and dextromethorphan that's used for PBA, pseudobulbar affect, which is often present in dementia patients. But this is the first one that got sort of full approval for treating agitation in dementia patients. Prior to that, it was just approved for schizophrenia and as an add-on adjunctive treatment for major depression. It is a very unique atypical antipsychotic, and in fact, some people think it should be in the third atypical group of antipsychotics. And this is data that was courtesy of George Grossberg. Dr. Grossberg is at St. Louis University, and he did the pivotal trials that were then analyzed by the FDA that allowed this medication to be approved. And this is a slide showing the combination of both 2 and 3 milligrams. The protocol you'll see in a minute goes up to 2, but you can actually increase it up to 3 milligrams. And it did show a very significant benefit over placebo and was thus approved for use. Side effects of brexpiprazole are not very significant. You can actually see the most common one being headache. Really no difference between the brexpiprazole group and placebo. And so it's generally well tolerated, and it does not seem to have the same kind of EPS that other antipsychotics do, I think, due to some of the real atypicalities of the pharmaceutical treatment with this medication. The dosing is important, and this is a very important slide. You have to dose this in a titration way by 1 week of 0.5 milligrams daily, 1 week of 1 milligram daily, and then after 2 weeks, in day 15, you can start the 2 milligram dose, and if necessary, increase to the 3 milligram dose. So this should tell you right off the bat that this is not a PRN medicine. This is not something you come on and nurses on the unit say, oh, by the way, this patient is very agitated. Oh, let me give them some brexpiprazole. No, it's not for that use. It's for patients that can wait, but you can also use some rescue medicines like some small doses of lorazepam while you're waiting for this to build up and have a benefit. So I want to cover a couple of special neuropsychiatric issues to consider. First, disrupted sleep. Well, we tend to avoid the benzos and Z drugs. Our patients with dementia do not do well with these. Plus the fact that you give a benzo for someone who is trying to fall asleep, and they fall asleep, but they wake up while that benzo is still in their system. And as you know, we don't have a smart benzo like a smart bomb that just goes to the anxiety or agitation centers of the brain. It goes everywhere, including balance centers and arousal centers. And so you get people that are much more likely to fall or have problems with cognition if they're regularly using benzos. Trazodone has been a staple. It's not perfect. It has a lot of sedation problems that can carry over into the next day. Mirtazapine, sometimes, if you wanted to combine some of the serotonin effects of that, it is sedating at night. And melatonin, I think most of us have found, doesn't do a whole lot in terms of helping this population, but could be tried. It can be very potent in helping the Parkinson's disease and dementia with Lewy body patients who are having REM behavioral sleep disorder. But realize when you do that, you're going to have to go to higher doses. Typically, I was always using doses somewhere between about 8 and 12 milligrams a day, some people even above 12 milligrams. We really don't understand how that medication treats the REM behavioral sleep disorder. Suvorexant is interesting. It was actually given an additional approval in 2020 to treat the sleep disorders of dementia, Alzheimer's disease. It is an orexin inhibitor. There's some belief that a lot of patients with dementia with sleep-wake cycle disturbances are secreting orexin at the wrong time in the middle of the night. I will tell you a caveat, a warning about this medication. It can cause cataplexy. So if you were to use it in patients, it's important for them not to be up and around and walking and have it start taking effect. They should be in bed. And it does have some slight sedation to help them in that regard, but you never want to use it in someone who has a diagnosis of narcolepsy or may have cataplexy from other issues. And cataplexy is this sudden losing of postural muscle strength, and people can just drop right down to the floor, and that's not good for our older patients. And consider light therapy. There's evidence that bright light therapy in the morning for 30 minutes at least can really help with evening sleep. And here in Tucson, we don't have to use the light boxes because we've got sun pretty much every day. And I just asked people if they had a deck or patio or outdoor sitting area that faces where the sun comes up, because you can watch that sunrise and get all the light you need. And by the way, if you watch it from a window inside, the window will filter out the light that needs to get into the brain to help. Apathy, really think about cholinesterase and memantine initially, because they can improve symptoms of apathy. Methylphenidate was shown to be very beneficial and helpful and without much side effects in studies in the past. Other stimulants, perhaps, maybe even bupropion might be helpful. Psychosis, of course, in PD and PDD, we would try the cholinesterase inhibitors, pimavanserin. And many patients with dementia and Lewy bodies who have prominent visual hallucinations can benefit from the use of donepezil, rivastigmine, or galantamine. I put a question mark with Seroquel, and they say that because, we use it a lot, it may not be a very strong antipsychotic, but it may help in terms of some of the emotional issues, and it does have sedation to it. So it certainly is often used. Clozapine, great choice, but with some side effects and with the negative impact of having to do weekly blood draws for the first 6 months and then biweekly after that. So a bit harder to use, and you have to be part of the registry to do that. And then judicious use of low dose risperidone. We're talking like 0.25 and 0.5. I think once you get up to above that, you're going to be risking, these patients kind of shutting down notorically. Lastly, frontotemporal dementia. We don't have any specific medications, but we have evidence that cholinesterase inhibitors and memantine really aren't helpful in this condition. SSRI medications may be helpful, and then prudent use of atypical antipsychotics if you're really dealing with behaviors that require that level. And one last thing about these antipsychotics, in nursing homes, not necessarily in assisted living yet, but in nursing homes, you're required to do some attempts to remove the medication so that you can see that the patient will not need it. And in the past, I can't tell you, we're going back 20, 30 years, how many people would just be left on medicines like Haldol and be sitting out in the hallway in a wheelchair with their head against the wall, half dozing, half weak. And, that's not in drooling, and that's not the way we want to see our patients. So please think about trials of decreasing dose and stopping these medications once the behavior has been controlled. There's no magic there. I think you don't want to do it like the day after all the symptoms are controlled, but you do want to at some point consider a reduction in elimination of that medication. So I did I think a pretty fast go through with that. This is my license plate in Arizona. in Alzheimer's disease, and that's my email there. Jordan, did I leave time for questions? I sort of went pretty quickly.
You did great, Alan. That was a tour de force, and you did leave some time for questions. So we should open it up. Let's see if any are coming through.
Yeah, I lost my screen for the questions. So if there's any you could read to me.
Yeah, there's there is a question that was directed towards Dr. Stahl, but I think that it may be good for you to answer this, Alan. In my 20 years of working with patients and their families with cognitive problems and assessing caregivers for burnout and stress, I do refer to support groups quite often, and I put in the chat here that folks could look at the Alzheimer's Association or Patients Like Me. But there's a question if online is as good as in person, and my feeling is that it is yes, indeed, that anything is better than nothing, and we know that telepsychiatry and telemedicine can be as good in many instances as face-to-face. So maybe you could speak about that.
Sure. So I had to get out of my pattern of being a bit old school. When I trained and of course did my psychotherapy training, I valued that being able to sit right there with the patient, right? And but I will tell you that the field has changed so much, and I speak to a lot of social workers when I meet them in public, for instance, or in other venues, and very few of them say they're ever going to go back to being in an office. They enjoy the work they're doing. There's data to suggest that it can be just as powerful and helpful as in person. So I think that it's going to be a wave of the future. Hopefully Medicare will continue to support that because that's important for our older patients. But yeah, I think we see pretty good results with virtual visits. Thank you.
There's a question that came in. What are the most common antipsychotics to be used in agitated dementia? Aripiprazole and brexpiprazole, are those only for Alzheimer's dementia or other types of dementia as well?
I think that's a very good question. And one of the things that I've always thought about is I'd like to stick to the medicines that have been trialed in this disease, right? Because only 4 of them have had good trials. Aripiprazole, quetiapine, risperidone, and olanzapine. They've been the ones that have been trialed. Now, that doesn't mean that others might not work. And of course, you saw where there may be an advantage at some point to use haloperidol. I always thought that a good one to use would be ziprasidone, and because of some of the side effects. But as you know, ziprasidone does have a little higher QT prolongation. So whether you want to go outside of those 4 and maybe experiment with that medicine, I think is reasonable. By the way, one thing about that medication, when they got it approved and did the studies for psychosis like schizophrenia, they actually did a geriatric subgroup. And interestingly, they did not have any significant elevation in that group of the QT beyond, a number that would concern people. So I think sometimes that QT gets a little bit exaggerated. And for example, just so you know this too, citalopram, has an issue with this. And the FDA a few years ago put a black box warning saying, you can't go above 20. And citalopram to date has one of the best studies in Alzheimer's disease, showing equal effectiveness in treating psychotic symptoms through their CITAD study. And I don't think there's data yet, Jordan, but we're waiting for the SCITAD study to come out. And the reason for that is the average dose of citalopram in the CITAD study was 30. So the average dose was already above what the FDA, after the study was done, said should be the maximum. And so sometimes if people want to use citalopram, I say fine, but if you get to 20 and even more, it's maybe time to shift to escitalopram or start escitalopram at the beginning.
I would like to just piggyback on what you're talking about here, because I think that this should be reinforced, that there is evidence that SSRIs can be as good as antipsychotics in managing the psychosis or psychotic spectrum diseases or symptoms that we see in dementia. And that if there's not an urgency that it's probably safer to start something like Lexapro or Zoloft because you're going to be addressing anxiety and the associated psychosis that can come from it. And I think that gets lost in translation too often. And coming from Pittsburgh, where these studies were done, it was drilled into my brain for many years.
Yeah, no, and I would echo that. And you know, a lot of times when we use these atypicals, it's not the psychosis may not even get better, but what's happening is the emotion, the emotional effect of these agitated behaviors are being relieved, which you can relieve easier with less side effects with the SSRI.
They're less bothersome. There's a question here that I'll just briefly, do we ever give clozapine PRN for dementia agitation? Absolutely not. It's a great question, but clozapine is part of a REMS program and it can't be dispensed without the pharmacy getting the blood draw. So, but I like that you're thinking out of the box. Alan, there's a question here. How do you screen for depression in dementia patients?
So many times we do a 15-item geriatric depression scale. It's a little easier than a 30-item. I might sometimes just even do a PHQ-9 when I'm actually with the patient because it's so quick to do. But the GDS is sort of, I think, what I would use and recommend using for primary care docs. 15-item is just as good. In fact, there is some authors that show that a 2-item GDS can almost give you about this somewhat similar results.
I would say that this question also speaks to the need for engaging caregivers in care planning and assessment, and asking caregivers if they think that there's a change in behavior that may indicate some depression, apathy. Well, apathy is a different symptom, but withdrawal, irritability, other somatic preoccupation is important and valid information. Here's a question, Alan. I think we have time for one more question for now. Do you ever add omega-3 and or lithium for adjunct treatment for patients with depression and dementia?
So studies have shown that the omega-3 data really isn't what it used to be thought to be. Okay, so I don't tend to do that. It's rare that I will use lithium. I have used it. You want to keep the doses low, which you don't need to go to high doses to augment. But yeah, I think lithium, I'd say sure at times, especially if you see a lot of mood dysregulation and mood vacillation. But I don't think that there's data to support omega-3 fatty acids are doing much in this population.
Great. I want to keep us on time, and I want to thank Dr. Anderson for this wonderful talk. And I think that he's going to be able to stay for the Ask the Expert section. So we'll be able to address more of these questions then. We have built in a 5-minute break for you all to grab a cup of coffee, take a bio break, and then be back here right at 10:29 or 10:30, because we're going to start right then to stay on time and get you on your way back to your regular Saturday. It is 10:30, and I want to stay on time to be respectful to all of you. It is an honor and a pleasure to introduce our next speaker, a good colleague, Dr. Pierre Tariot. Dr. Tariot is board certified in internal medicine and psychiatry with added qualifications in geriatrics. He was a fellow at the National Institute of Mental Health and then served as a faculty at the University of Rochester Medical Center, and since 2006 has served as the director of the Banner Alzheimer's Institute in Phoenix. And he's also a research professor of psychiatry at the University of Arizona College of Medicine. His work has focused on the care and study of people with and at risk for Alzheimer's, with an emphasis on design and implementation of clinical trials for depression or for prevention and treatment, development of biomarkers, characterization and treatment of neuropsychiatric features of dementia, and demonstration of effective dementia care. He has published mind-blowing 450 papers on these topics, and he has participated in FDA trials that have led to the FDA approval of new medications. I also just want to sort of contextualize Arizona or geriatric psychiatry and dementia care in Arizona. So Dr. Anderson is a geriatric psychiatrist. He leads the Banner Alzheimer's Institute in Tucson. Dr. Tariot is a geriatric psychiatrist. He leads the Banner Alzheimer's Institute in Phoenix. Their boss, Dr. Eric Ryman, is a geriatric psychiatrist. He's sort of the Alzheimer's czar of Arizona. It is geriatric psychiatrists who work closely with neurologists, but we are the ones who are the expert in managing the behavioral, cognitive, and social conditions that are associated with dementia. So really honored to have Dr. Tariot here, and I will turn things over to him.
Good day, everybody. Pierre Tariot, as you heard, internist, geriatric psychiatrist, and enthusiastic dementia physician for reasons I hope will become clear. This wasn't my title. Dr. Karp chose it, but I'll try to emphasize what's good and bad and beautiful and ugly as we go. And let's see. My disclosures have been shown elsewhere. Here they are. I consult to a lot of companies. I don't have commercial activities. So just to set up the talk, which is more or less going to be in two parts, a little bit about what goes wrong in the brain. Nerve cells die, as you can see in the lower left, two age-matched brain halves at autopsy. You can tell the one with the extensive atrophy. There is misprocessing of the amyloid protein, resulting in extracellular puffball deposits of amyloid called plaques. There is misprocessing of the tau, TAU protein, resulting in dense intraneuronal deposits called tangles. There are well-characterized changes in brain neurotransmitters, which are the basis for most of the symptomatic therapies. I should add there's considerable other pathology as well, molecular pathology, cell cycle dysregulation, membrane dysfunction, inflammation is a major player that we don't adequately understand. But I'm going to break the talk into first the older symptomatic therapies that you may be fairly familiar with, and then the newly approved, FDA-approved therapies targeting amyloid. So Jeff Cummings is a major figure in our field, and he writes these Olympian pieces every now and then. And there's one that's almost 20 years old, but I think it's still a good way to define symptomatic versus disease modifying. So symptomatic, you might help cognition, improve or delay functional decline, ameliorate behavioral symptoms, but you don't attack the underlying biology. Whereas with disease-modifying therapy, you produce an enduring clinical change that's measurable by attacking the underlying disease biology as proven by biomarkers. And that's actually where we're at now. That'll be the latter half of the talk. So the older meds, Tacrin, donepezil, rivastigmine, galantine, memantine, all 20-ish years, 30 years old, all FDA approved for various stages of Alzheimer's dementia, not mild cognitive impairment, different formulations. For instance, donepezil has a once-a-week patch, rivastigmine has a once-a-day patch. Several of the medications are generic, some are not. Just focus on the left here. A quick reminder about the biology underlying the clinical effect of acetylcholinesterase inhibitors. Acetylcholine, the electronic signal, so to speak, is converted into a chemical signal at the synapse of a cholinergic neuron. As acetylcholine is released, it binds postsynaptic receptors, and its activity is curtailed by getting it chewed up by the cholinesterase. And this class of agents blocks the function of acetylcholinesterase, prolonging the physiologic effect at the synapse. And it's rather remarkable that such a simple mechanism actually has clinically discernible benefit in Alzheimer's disease. So going from left to right, the cholinesterase inhibitors are not approved for mild cognitive impairment or MCI, but it's considered best practice to discuss with people the evidence, the glass is sort of half empty or half full about the impact of cholinesterase inhibitors in that stage. All of the agents are approved for moderate to severe, for mild to moderate dementia, and donepezil and rivastigmine are approved for severe Alzheimer's dementia. Basically, there's some benefit with cognition that's discernible, some preservation of global status, and inconclusive but encouraging evidence about effects on behavior. This is essentially a cartoon that I draw for my patients and families before I start one of these therapies. It's from a year-long placebo-controlled trial of donepezil done in Europe decades ago. The change in mini mental state exam on the y-axis, weeks up to a year on the x-axis. Up is good, down is bad, blue is drug, fuchsia, I guess you'd call that, is placebo. And the takeaway here is that after a year of treatment, you're about a year better off on treatment versus placebo. And that difference kind of holds up over time. The longest placebo-controlled trial that we've done, that has been done, is 2 years, and it shows a similar kind of pattern. People will lose ground over time, but will generally do better on treatment than off. How about memantine on the right side? It's a moderate affinity, reversible, uncompetitive NMDA antagonist at glutamatergic receptors. We actually don't know for sure how the medication works, but probably through modulation, sort of toning down glutamatergic neurotransmission. Memantine, unlike the cholinesterase inhibitors, so different mechanism of action, and only approved for moderate to severe dementia. That's the only clinical space where benefit has been demonstrated. For instance, this was the monotherapy study, one of the 2 studies leading to FDA approval. These are people with quite advanced Alzheimer's dementia, mini mentals around 10 to 12. This was a cognitive measure designed for more advanced disease. Down is bad, up is good, black is placebo, purple is drug, and a similar sort of slowing of worsening over time. No benefit has been seen in mild Alzheimer's dementia, and the drug has not been studied in mild cognitive impairment. This is an oft-cited study that I was involved with, looking at what happened if you added memantine onto donepezil in people with fairly advanced Alzheimer's dementia. And up is good, down is bad, blue is drug, black is placebo. And in this study, people actually showed sustained benefit over baseline for up to 6 months. So this drug is FDA approved for treatment of moderate to severe Alzheimer's dementia alone or in addition to a cholinesterase inhibitor. I'm assuming you'll have the slides, so I'm not going to dwell on the details of dosing and formulations. It's here if you wish, but some takeaways, all of them require titration, and side effect rates among the cholinesterase inhibitors do differ and are generally less with the more expensive transdermal formulations. Very different side effect profile with the cholinesterase inhibitors versus memantine. Cholinesterase inhibitors not only stimulate cholinergic function in the brain, but the gut as well. So it's not uncommon to have nausea, vomiting, diarrhea, loss of weight. This figure about a 1 in 4 chance of that happening and being clinically relevant. Memantine, single digit side effect rates that are quite different. Dizziness, headache, constipation, confusion, all listed in the prescribing information. I personally have never seen constipation that I could attribute to memantine, but it's in there. We have a great chat question that I'm going to hopefully address on the very next slide. So how do you practice with these agents? And this is in a way off label. This is sort of clinically driven decision making. This is actually from a published guideline from a well-known geriatrician named Howard Phillip. It's old, but I think it holds up well. So the guidelines suggest, and I basically agree with most of these comments, newly diagnosed patients with mild Alzheimer's dementia deserve a trial. Memantine add when they progress to moderate Alzheimer's disease, or they're newly diagnosed with moderate Alzheimer's disease. Newly diagnosed severe Alzheimer's dementia, treat with memantine. You can add a cholinesterase inhibitor. If in mild cases of Alzheimer's dementia, the cholinesterase inhibitors are not tolerated, memantine monotherapy could be considered, or consider adding it if there's rapid progression. A somewhat controversial suggestion is that patients with mixed, for instance, Alzheimer's and vascular dementia could be treated according to Alzheimer's guidelines. Cessation of therapy, we may want to come back to later, but in patients with profound disease who have lost all cognitive and functional ability, but do maintain therapy in the hospital if somebody's got an intercurrent medical illness. Okay, part 2, hold on to your hats. Let's see, and somebody's asking if you need to diagnose Alzheimer's dementia. I would suggest yes, but that's not that hard to do. You can use clinical criteria for that kind of decision making. We'll get to biomarkers in a little bit, and if I didn't answer the question adequately, come back to me. So let's ignore the details here. Once a year, Jeff Cummings publishes a paper on the pipeline for Alzheimer's drug development, and let's just focus on the external, the labels on the outside. 2/3 of the agents in clinical trials this year are disease modifiers, either biologics at the top or small molecules, sort of lower left. The blue wedge is the number of neuropsychiatric drugs in development. And then the sort of orangish color is the cognitive enhancers that are in development. So roughly 125 drugs are in clinical trials right now. I'm going to focus only on those that are at or near FDA approval. And I have to click on the slide. Here we go. Why? So out of all these agents in the pie that include anti-infective, anti-inflammatory, and so forth, why has there been so much fuss over amyloid? Well, amyloid plaques are a neuropathological hallmark of the disease. I didn't tell you this, but abnormally processed amyloid fragments are highly toxic. If amyloid buildup is identified in the brain, my brain, let's say I'm walking around doing fine, but I have elevated brain amyloid, I have about a 35-fold chance of developing frank Alzheimer's dementia fairly soon. What I haven't told you yet is that the rare causes of familial Alzheimer's disease, autosomal dominant, fully penetrant, all involve amyloid dysregulation. And conversely, a very rare mutation that blocks amyloid misprocessing essentially prevents Alzheimer's disease. So the genetic backdrop is a major factor in the focus on Alzheimer's treatment with anti-amyloid drug. And so what drugs are best? Can we stop this cascade? And if we can, when is the best time to intervene? So I'm going to talk chiefly about the 3 monoclonal antibodies against amyloid that are in various stages of FDA approval. So aducanumab, intravenous every 4 weeks. It's in phase 4. It has provisional or accelerated approval from the FDA, and that's led to a bit of a mess that I'll tell you about. Note all the way to the right this thing called ARIA, amyloid-related imaging abnormalities. I'll come back to that, but that's sort of the biggest concern in terms of safety. So ARIA rates of 35-ish or higher across the aducanumab trials. So it's got partial FDA approval. Lecanemab intravenous every 2 weeks. It was originally given breakthrough designation, and it worked in phase 3 and has traditional FDA approval, CMS has announced that it will cover the treatment, it is being studied in 2 prevention trials and has quite a low rate of this thing called ARIA. Gantenerumab, just take it off the table. The large phase 3 program failed. Donanemab intravenous every 4 weeks, but only until amyloid is cleared. Phase 3 just completed. It's been given breakthrough designation, and full FDA approval is anticipated, but not guaranteed, in early 24. And it is also in prevention trials, and it has a kind of intermediate ARIA rate. So here's kind of what it looks like. Aducanumab, just work with me for a minute. These are pairs of amyloid PET scans 1 year apart in 4 individuals. The pair at the top is an individual who received placebo. Orange and yellow are the bad colors. You see there's essentially no change in the amount of orange in these PET scans. But then the next 3 pairs are individuals at baseline in 1 year at ascending doses of aducanumab, showing for the first time in history that you could clear pathological amyloid from the living human brain. That was a very big deal and was the go signal for a global phase 3 program with aducanumab. 2 parallel trials, Emerge, Engage. Primary outcome in all of these newer studies is some kind of global measure of severity of dementia features. A futility analysis was conducted, except the conditions for conducting a futility analysis were not actually met because the treatment effect was different between the 2 studies. And here's the takeaway. When the data all came in, the one study called Emerge showed it's a little hard to see. I don't know if you can see my cursor, but kind of in the middle of the upper box, 22% less worsening on high dose aducanumab versus placebo over about 18 months. The other trial, virtually identical, no effect. So what do you do with this? The FDA agreed to review the file and granted provisional approval based on the biomarker finding of reduced amyloid being correlated with clinical benefit as less worsening. So less worse by about 22% over 18 months. About 35% had this brain swelling called amyloid-related imaging abnormality dash edema. Most asymptomatic, much higher rate in ApoE4 carriers. Homozygotes had a 60% rate of this swelling. So as a result, you have to monitor MRIs frequently. Medicare is not covering the medication. A phase 4 trial is being done. So kind of a patchy history, unfortunately. The next just a bit about ARIA. So ARIA rates range from a low of maybe 12-ish% on lecanemab up to 35 or more percent on aducanumab, intermediate for donanemab. Usually asymptomatic. Here are 2 examples of what MRIs look like. If there are symptoms, which occurs in probably less than 10% of cases where ARIA is shown radiographically, things like headache, confusion, visual disturbance, gait disturbance, sometimes nausea, vomiting, very rarely seizures. Okay, so this is the kind of biggest handicap of this class of agents. Lecanemab, full FDA approval. Here is the sort of top line results from the phase 3 trial completed last year. So and most of the trials are similar, mild cognitive impairment or mild dementia due to Alzheimer's disease demonstrated by elevated brain amyloid based on PET scan or spinal fluid testing. Here's just sort of a focus on the left graph here. Down is bad, up is good. The upper curve is lecanemab, the blue curve is placebo. After 18 months of treatment, 27% less worsening. And then on the right, some other findings, marked removal of amyloid, similar clinical results with key secondary outcomes. And this resulted in full FDA approval. And again, the ARIA rate around 12% overall, but higher in persons who are E4 carriers. And then I didn't mention the sort of second tier main adverse event, which is microhemorrhages, ARIA-H. Don't like to see them, but they don't seem to be associated with too much mischief clinically. But if somebody has more than 4 microhemorrhages at baseline, that may be the footprint of cerebral amyloid angiopathy, which means that person shouldn't get treatment. And if they get showers of microhemorrhages, probably a clue that they have CAA and shouldn't get the drug. How do patients actually get lecanemab? This is not something I anticipate in my suburban family clinic. Let me go there. Actually, let me go there in just a minute. Great question. This is a great publication on the nitty gritty of how you might use lecanemab, which is the only monoclonal with full FDA approval. But in a nutshell, what in primary care, and we do a lot to try to support our primary care colleagues who have such a heavy burden in general and a heavy burden of persons with dementia. What I might suggest is that if somebody expresses concern or you have concern about your patient, go ahead and do a focused history, focused exam to be sure they don't have things like stroke or Parkinson's. Some simple objective testing could be the mini-mental or the MOCA. And if they seem to meet clinical criteria for dementia, possibly of the Alzheimer type, you could refer to a specialist, or as I'll come back to in a moment, you could consider biomarker validation and only refer if they actually have evidence of Alzheimer's neuropathology. One slide on donanemab, which has shown the largest clinical benefit. I didn't call it out here, but about a 37% difference in slowing on the primary outcome, and a bunch of secondary outcomes supported this, lots of amyloid removal. This program has resulted in accelerated FDA approval, but it won't be marketed until traditional approval is offered, now delayed until Q1 of 24. Two things unique about the donanemab program. Patients were selected in part on evidence of elevated tau pathology in the brain with PET scan. That wasn't the case for the other monoclonals. And interestingly, in this program, treatment was stopped if there was amyloid PET scan evidence of amyloid clearance, which happened in about 2/3 of people at a year, almost 80% at 18 months. So that's a very different approach to treatment. So I think this may be about my second or third to last slide. This looks kind of goofy, but it's actually very simple. This is right out of an FDA approval letter. The y-axis is change in a global measure of dementia severity. Down is good. The x-axis is change in amyloid. Left is good. What the FDA pointed out by pooling all these experimental studies together was that there was a moderate correlation between amyloid removal and clinical benefit. And this has been the basis of a lot of their approval activity. So, second to last slide, I wanted to just to point out to you that there are FDA-approved techniques for establishing the presence of amyloid and/or tau pathology in the brain. CSF measures are FDA-approved. PET measures are FDA-approved. Blood measures, some of them are CLIA approved, but not FDA-approved. But I believe that we're about a year or two out from having FDA-approved simple blood tests that will, with a high degree of confidence, tell us whether or not somebody has amyloid pathology in the brain. This is my last slide, then I'll come to some of the questions that have popped up. Where to from here? Well, remember that phase 3 trials designed to achieve marketing approval from health authorities don't inform practice. So we need phase 4 studies and a lot of clinical experience to figure out things like, how long do you treat? Do you titrate more slowly in people who carry, for instance, 2 copies of the ApoE4 allele? Once you've cleared amyloid, what do you do? Do you give just periodic lower doses? Do you stop and just observe? If one drug doesn't seem to do a very good job, do you switch to another one? All of these things are unknown right now. What drives ARIA? We're not sure. Can we mitigate ARIA better than we have so far? Probably. One big change that's looming is the possibility of subcutaneous administration. All of these drugs are being studied in subcutaneous forms. Lecanemab data just came out showing good tolerability in general and safety, but similar rates of ARIA, which was a bit of a surprise since we're not getting peak levels. But this could be a game changer, you know, instead of going to an infusion center, using an auto-injector at home would be great. There are additional antibodies in development being designed to avoid adverse effects. So, for instance, there's a follow-on compound to donanemab named remternetug that the sponsor feels may be better tolerated. A big deal is preclinical studies, which we've done a lot of. The 2 active ones with these agents are one called AHEAD. This is in persons with elevated brain amyloid, but no symptoms. The other study called Trailblazer 3, which we are doing in partnership with the sponsor, Lilly. Here are your eligibility criteria: age, normal performance on a telephone cognitive test, and a blood test result. That's how you get in. So that's the good, bad, and the ugly. Some questions online. What biomarkers for AD can a primary care doctor order? You can order any of them. Maybe I should go back, since that seems to be of particular interest here. Give me a second. Oops. Okay, try again. The most widely used CLIA, but not FDA-approved blood test is through C2N, a company called C2N with their Precivity assays. The spinal fluid assays that are FDA-approved are through Roche Diagnostics. And then there are CLIA-approved blood tests with Quest, Quanterix, Sysmex, LabCorp has a recent one, and so forth. So I think it's going to become much simpler in the not too distant future, where practice guidelines will be spelled out for folks. Okay, so that's where I'm going to stop, and we have a few minutes for questions.
Pierre, you're doing a great job of monitoring the questions and picking them yourself. Do you want to continue?
Sure. Somebody asked a great question. I heard CMS approved PET scans. Have you tried ordering this yourself yet? We have we have 2 PET CT scanners in our building in Phoenix. We have no trouble getting these done. We are waiting. So I'm not a insurance expert, but I actually looked at the CMS website in preparation for our program today, and what the website says is that the regional authorities called MACs are going to make determinations for their regions about what the eligibility criteria are, what the cost will be, whether you can order serial PET scans, and the answer, philosophically, they want that to happen. So it's imminent. I think if I tried to order get CMS to cover a PET scan today, it would probably take a while to get an answer, but I don't bank on that 100%. Okay, one new message. What is the difference between CLIA approved and FDA approved? Thank you, Jordan. I think if I were in primary care, I would care only about FDA approval. That's the FDA saying that something is safe and effective and can reasonably be used to optimize how somebody thinks, feels, functions, or survives. CLIA approved is a more technical laboratory processing approval. You need both, but it's sort of the FDA seal of approval is the one that matters to me the most if I'm in practice.
Will insurance pay for CLIA approved but not FDA approved blood plasma test?
Highly variable. The traffic is so low that we don't usually have problems, but sometimes we do. More and more people are using, self-pay to order their own blood tests. The trouble is that those that are available sort of direct to consumer have the lowest analytical validity, the lowest specificity and sensitivity, and you don't have the kind of built-in counseling that's necessary to properly interpret them. So I right now, and I know we're just about out of time, right now, here's how I use blood tests. I discourage them in general in the clinic, but if somebody says I want to use it as a triage step, I will consider that. That is to say, if it's positive, then we agree in advance to go on to formal validation with PET scan or spinal fluid. Those are the 2 techniques right now that are the most ironclad and supported by, for instance, consensus statements from the NIH and Alzheimer's Association. We're right on time.
Yeah, no, that was fabulous. Thank you, Pierre. That was you made a complex concepts very accessible and easy to understand. So thank you so much for spending time with us today.
Great to be invited. Thanks.
I'm now delighted to introduce our next speaker. We have Dr. Fain and then the Ask the Experts session. And Dr. Mindy Fain is another good friend and colleague. She is the Ann and Alden Hart Professor of Medicine. She's a professor of nursing. She is board certified in internal medicine, geriatrics, and hospice and palliative medicine. And she co-directs the University of Arizona Center on Aging and is division chief of general internal medicine and geriatrics here at the Banner University Medical Center. She has expertise in geriatrics, palliative medicine, frailty syndrome and resilience, and she is the consummate educator. I could go on and on for Dr. Fain like everybody else here, but I want to turn things over to her so she can teach us.
Is my slide showing? How are we doing?
It looks great.
All right. Well, just what a wonderful morning with such terrific speakers. I've spent the whole morning just learning so much, and I'm looking forward to talking with you all today about frailty and helping patients age safely in place, really building on what you heard all morning and then learning from questions and comments. So this is going to be the path today. We're going to briefly talk about what we mean by aging in place, and then, kind of what's involved, move on to frailty, kind of 101 frailty, then a discussion of how frailty impacts on older adults' ability to age in place, and we'll end with a call to action or next steps. So just to start off with a reminder that most older adults live at home in their community. Only about 3% of people over the age of 65 live in nursing homes. And for those of us in healthcare, we get a really weird view of aging when we just work in hospitals or clinics, especially following the COVID pandemic, where it seemed as if kind of all older adults lived in nursing homes. Just want to remind everybody that most older adults live at home. And surveys support that nearly 90% of older adults wish to remain in their homes as they get older. And it's for multiple reasons. And you can take a moment to think about why that's so appealing. The independence, the ability to live on our own terms, our own schedule. Certainly for many, the safety of being in familiar spaces, even though when we may visit people in their homes, it may not look that safe to us. From the person's perspective, it feels safe and comfortable. There's access to families and friends, can't discount the importance of the memories that live in that home, and then the ability to be, part of one's community and to continue in some way to contribute to society. So these are just some. You can probably add other reasons why that would be. And so aging in place, it works best when the person, the place, and the support network are all in place and all working together. And as most of you know, it requires preparations and resources. And we'll talk more about that. However, frailty, and by that I mean the syndrome of frailty, which we'll go into, is a very common and really important barrier to being able to successfully age in place. And importantly, hopefully by the end of this session, you'll see that there are ways to overcome these barriers so that more people can age in place if they want to. A lot depends upon our community's priorities. And so this kind of brings us to learning about frailty. So just want to make sure we all understand frailty. Some of you know it well. Many others maybe likely not so well. And so we're going to talk about what it is, why it's important, the different schools of thought, the tools that one can use to assess frailty in your patient, and then considerations for management. So we'll start by trying to put frailty in perspective. And as you know, there are vast differences in the way people age. There's just this enormous heterogeneity. And on the left-hand side of this slide, there's my sense of what usual aging is. And again, very variable. You've seen one 80-year-old, you've seen one 80-year-old. They're all very different from each other. And then moving to the right side of the slide, I want to highlight these geriatric syndromes and conditions, which are not usual aging. We're all familiar with dementia, learned wonderful things about it today, a common syndrome, not part of aging. Frailty is not part of normal aging. Frailty is another syndrome, common, not normal aging. And defining frailty is like not a really easy thing to do, because the word frail is a common word that we use in our everyday language. It kind of confuses things. People, both professionals and lay, think that they know what it means, kind of like an adjective, a frail person. But importantly, in healthcare, frailty is not an adjective, it's a noun, it's a geriatric syndrome. So a lot on that, but just want you to remember that frailty, not part of usual aging, it's a syndrome. Okay, so what is it? It's an age-related, very precipitous decline in function and reserve across multiple physiologic systems. It's clinically recognizable Importantly, it's unexplained and represents kind of disproportionate and exaggerated response, often, to a stress that can often be minor. The picture of the orchestra there on the slide reminds me that it's kind of, I understand it kind of like an orchestra without a conductor and missing several instruments. And so things are really discoordinated. It can be seen as kind of an inability to bounce back, again, from even a minor insult. During stress, these limited reserves become even more apparent. And frailty identifies a very high-risk, vulnerable population. It's accepted as in many ways the most sensitive predictor of poor health outcomes. We don't know much about the cellular and molecular biology of what drives frailty, although there's evidence that there's chronic inflammation, some disruption of the autonomic nervous system, and some dysregulation of energy. Again, the key is that it's not normal aging. I'll probably say that multiple times over this session. And it's really common. It's about as common as Alzheimer's disease and related dementia. It's about 12 to 15% of the older population are frail. By age 85, nearly 40% are frail. And it's more common in minoritized populations and in those who are live in lower income groups. One concept about frailty is it's considered dynamic. There are kind of three stages: non-frail, pre-frail, and frail. And about 30% of people over the age of 65 are pre-frail in that middle group. So as we discussed, frailty is a very sensitive predictor of poor health outcomes. And again, one of the most sensitive we have. And some of the poor health outcomes are listed on this slide: recurrent emergency department use and hospitalization, a 5-time prevalent of falls with hip fracture, increased post-op complications 2 to 3 times more. I want to point you to the institutionalization. Frail older adults are 20 times more likely to be institutionalized, and that has a lot of importance when we're talking about aging in place. So to really grasp what frailty is, I like sort of quickly reviewing the history of how frailty came to be recognized as a syndrome and not normal aging. And it's very similar to some of the early confusion about Alzheimer's disease and related dementias. The idea, certainly, many years ago, was that dementia was normal aging. We called it senile dementia. And that sort of is similar to how many began to think about frailty. For a long time, it was a description of just, advanced aging, a risk of poor outcomes, and it was mostly like a statistical concept. But in 2001, it was sort of a banner year for frailty, and partly as a result of people living longer and longer and longer, which we all know, rapidly aging population, and lots of people studying aging, including some geriatricians at Hopkins, trying to really better understand this heterogeneity, to better understand this kind of subset of older people who seem to be doing well, who then rapidly declined, very precipitously declined for no clear reason. And so the concept of frailty was born. And with it, the development of 2 main schools of thought about what it is, how to screen older adults for frailty. They were the Fried phenotype and the Rockwood cumulative deficits. If you can think of sort of plaques and tangles and things like that, there are parallels with dementia. So we're going to start with Fried. It was the first school, biologically based syndrome. That was how they envisioned it, called phenotype frailty. And it was developed by Linda Fried and her colleagues, Jeremy Walston at Hopkins, again in 2001. And caring for all these patients who were rapidly declining, they tied together what they kind of clinically recognized as the key components of frailty, things like sarcopenia or declining muscle mass, fatigue, exhaustion, reduced strength, reduced activity, a slow walking speed, and they pulled it together into this sort of hypothesized a cycle that was then termed the Fried physical frailty phenotype, a biologically based syndrome. And they tested this in the cardiovascular health study. There was about 5,000 patients using measures from this study, like weight loss, grip strength, walking time, that they felt were surrogates for those clinical domains that they recognized. And then they operationalized this model. And they demonstrated in these folks very poor health outcomes among people who measured as frail. And what's important is in this conception, frailty is different than comorbidity, which is having multiple chronic conditions, or disability. Again, that's measured by ADLs and IADLs, which we heard about earlier today. And in this model, 25% of these patients had neither a disability or comorbidity. And so frailty, again, with Fried, is described as a biologically based syndrome. And this is the Fried tool. It takes the clinical characteristics of frailty and matches it with a really specific way to measure it. So, for example, weakness is measured by grip strength with a special instrument, a dynamometer with specific cutoffs for gender and age and weight and so on. And all of those you can see down on the slide. It's scored from 0 to 5. It takes about 5 minutes. But what I want to point out is that it does not include cognition, which is really important. The second major school, called the deficit accumulation model, has a totally different approach. Needless to say, there were conflicts between these two schools. And this was proposed by Kenneth Rockwood and his team, who believed that frailty is really the result of unrelated aggregates of problems in cognitive, medical, function, social domains. And really, it's a mathematical thing. The more conditions you have, the more frailty you hit a tipping point. And all the deficits were really interchangeable in these measurement tools. And so there was likely no common biologic etiology. And in this model, disability and comorbidities are really integral to the idea of frailty, and not just things that can be caused by frailty. And this is the way that the Rockwood model, the deficit accumulation tools, is measured. On the left is in the electronic health record. There are ways to extract data from the EHR, an algorithm to screen for frailty. But again, many of electronic health records don't include or easy access to things like functional status or the other domains. So in certain instances, it limits its usefulness. On the right is what's called the Clinical Frailty Scale, or CFS pictogram. And that's one of the most commonly used frailty assessment tools in clinical practice. If using the CFS, it's really important to interview the patient, family, people who know the patient, to really get a sense of what the true baseline is, and not just go by the pictorial, which really invites ageism. So it's important to know you can't tell frailty by looking. We tested this in 2016. It seemed really important to do because we were hearing a lot about clinicians kind of rejecting the need to use a tool. And we found that you can tell by looking. We objectively measured frailty status. We used the Fried frailty score, which is what's used in most research studies. And we found overall, using expert clinicians in a sample of older patients, only 44% agreement. And this was at the extremes, only the most robust or the most frail. And it's important to remember frailty comes in all shapes and sizes. The word frailty brings to mind the idea, and we have a picture of a little old woman bent over walking slowly with a cane, but frailty can as often be an obese old man. So the message is like, don't use the eyeball test. And this marathon runner is a great poster person for why we really can't tell by looking. So I showed you the two most common scales or tools. So there are lots of scales. There are like over 75 of them, and they're all quite different. And there's always a trade-off between, sensitivity and specificity, time, burden of doing it. Some are pencil and paper and can be done almost by the phone, and others may have components of in-person measures like a sit-to-stand. What's really confusing but important to know is that these scales measure different populations. So if you take people who are measured as frail by Rockwood and compare them to those measured as frail by Freed, there's very little overlap. And we don't know quite what to do with that. They still show high vulnerability and high risk of poor outcomes, but it's identifying different populations. So now that we've reviewed what frailty is in some schools and some tools, the question is why screen for frailty in the care of older adults at all? And here are some things to consider. Right now we aren't able to prevent frailty right now. There's some things we might be thinking about. Maybe in the future we could, but we can risk stratify, avoid harm, bring in more resources to folks who are frail. And in doing so, hopefully optimize health and improve health outcomes. And we know that in many clinical sites, patients are not routinely screened for frailty, and it's for a lot of reasons. No standard definition, unclear who we screen, who we assess, which tool to use. I can go on. Also, evidence base is lacking. We're really not confident about what to do once we've identified someone as frail, what to do to make a difference. And then, because frailty is not a well-known diagnosis, it's especially hard how to share it when many of our patients haven't even heard of it. So do we have any ideas as to how to prevent or manage frailty? And as I mentioned, there aren't any frailty-specific evaluation or management guidelines once patients screen positive, but there are some general things that we can do. A comprehensive geriatric assessment and a team-based plan of care is strongly recommended, recognizing that the differential diagnosis, the things that can cause frailty can be broad when we think of the predominant symptoms and signs. For example, if there's profound weight loss, that might move us in one direction, or profound fatigue. But what we currently believe, and the rocket is there to remind me, to say really isn't rocket science, but it's pretty basic and can be helpful. And some data is supportive, and we're going to go over it in the next slide. So here are some specific interventions that may improve health outcomes. Most recommendations end up being multimodal. It's hard to find that one specific area really makes a difference, but several different areas of intervention are recommended. And things like attention to nutrition, especially high protein, is really important. Chronic disease management and a reduction of polypharmacy, potentially harmful medications, is important. Opportunities for meaningful activity, emotional support, and socialization, can't say enough about it. And physical activity, strengthening range of motion, aerobic support helps even the most frail. And in certain studies, it helps the most frail even more than any other group. And the benefits can be broad. It can include reduced emergency room visits, hospitalizations that are potentially avoidable, reduced falls, and improved activities of daily living. So now that we kind of have a handle on frailty, and you'll figure out which school you belong in, I guess, Freed or Rockwood, we're going to return to aging in place. And I wanted to start with just general considerations for all older adults. Like, what should we consider when we think about supporting someone to age in place? And as just a high-level framework, there are 4 domains that I think come to fore. One is the person and their and what matters most to them, as mentioned earlier today, along with their unique physical, emotional, or cognitive issues, their function, what their insurance is, what are their financial means, because we know that those with financial means are more likely to be able to age in place. Their home and neighborhood is really important, as home modifications are often needed, and it's important to at least have a sense of neighborhood support and safety. Informal supports, meaning friends, family, neighbors, church, access to a caregiver, as we heard about in detail earlier too, really important. And last, what the formal health system and community-based resources and services offer, such as home-delivered meals, transportation, senior centers. Nearly every county has senior care and services to support aging in place. And most are available regardless of income or assets. And you've heard some of these mentioned before: delivered meals, visiting nurses, transportation, senior centers. Now, poor health alone doesn't preclude aging in place, but several factors can decrease the chance of success. And so this brings us to talk about frailty. Frailty impacts significantly on aging in place. And I'm going to, take us all through 7 issues to consider, broad issues. As we go through each, we're going to discuss how frailty specifically poses a challenge, and then for each, some suggestions to overcome those barriers. And the suggestions are not exhaustive, and in many places they're duplicative, but again, they cover key areas. So apropos to this wonderful program, let's begin by considering depression. There's a higher prevalence of depression in those with frailty. For those with mild to moderate late life depression, there's a higher prevalence of frailty, about over 40%. So they kind of interact. And there's some evidence that antidepressant therapy is less effective in persons who are frail. We know that we believe that the combination of depression and frailty results in really worse clinical situation, with some evidence that there's more disability and more cognitive decline. If someone is identified as frail, it's important to screen for depression and provide access to treatment, the support and resources that we heard about today, and research really to determine the best treatment options. Again, they may have this frailty and depression, share some symptoms together, and they may share some etiology. And so sometimes it's hard to disentangle them, but it's important to recognize if you have someone who is frail to screen for depression. Next, consider cognitive impairment. Frail older adults are at a higher risk of cognitive impairment. The combination of cognitive impairment with frailty results in a very accelerated downward cycle with a very poor global prognosis. It's actually called cognitive frailty. And so for frail older adults with cognitive impairment, comprehensive and coordinated home support is really critical. And again, as we heard earlier, attention to caregivers, to how to provide ADL support and IADL support in home safety. Next, just consider the risks of usual health care for frail older adults. So frail older adults, we heard poor health outcomes. They're at high risk for exacerbation of chronic conditions, falls, and so on. And this results in, often recurrent emergency room visits and hospitalizations, and they do very poorly in the hospital. We know usual care is really hard on older adults anyway, and it's especially so for frail older adults. They suffer hospital-associated complications like delirium, functional decline, deconditioning, falls, often discharged to skilled nursing facilities, and they suffer the decline of loss of home and loss of place. Much of this utilization is avoidable and we have we know what can work: in-home primary care teams to manage chronic conditions, identify and manage problems before they're emergencies, and importantly, as we heard before, to identify what matters most and to provide palliative care when it aligns with what matters most to older adults. Next, want to consider sarcopenia and the impact of that. We lose muscle mass with usual aging, muscle mass and strength, but sarcopenia is the rapid and accelerated loss of both strength, mass, and power. And it's a disease. It's a core component of most frail patients and brings with it a really high risk of fatigue and falls, compromises one's ability to age in place. And support for this includes access to nourishing meals, maybe at a either home delivered or a senior center that are high protein, physical rehabilitation, home safety modifications, access to assistive devices, and DME. And next, financial means and financial stress. Everything's expensive. In-home care, cleaning, a bunch of things are listed there: home modification, meal delivery, caregiving, transportation. And this is really where home and community-based care and services can truly make the difference. Next, to talk about social isolation and loneliness. If we think of frailty as the state of vulnerability, dependency, and decline, and the fatigue, exhaustion, weakness, the other complications, depression or cognitive impairment, you can readily see how it limits the frail person's ability to really engage with others, and it often results in social isolation and loneliness. So for frail older adults, we really need to think about how to assure access to socialization, meaningful activity, emotional support, and to bring joy into their lives. And last, and most important, and as we heard earlier in that wonderful talk, to consider caregiver stress. Caring for a loved one who's frail can be really hard, supporting their ADLs and IADLs, mood and cognition, managing chronic illness to avoid these recurrent ED visits and hospitalizations, managing the medications, coordinating the care, monitoring their signs and symptoms. It's really exhausting, fulfilling for many and exhausting. So we need to think about how to provide comprehensive in-home caregiver support, along with things like adult day health care and transportation. These are critical pieces of being able to age in place. So most people prefer to remain in their homes as they age. And it's important to, if you're caring for these folks, to screen for frailty, to be able to anticipate and prepare for these barriers to be able to age successfully in place. So a few brief summary slides. In summary, Frailty 101. Again, common age-related syndrome, among the most sensitive risk factor for a vulnerable population and for poor health outcomes. Hopefully in the future, we'll know how to prevent it. It often goes unrecognized. It's not usual aging. And again, the focused assessment really gives us the opportunity to identify what matters most to people, to risk stratify, avoid harm, focus on management, and improve health outcomes, and to help them age in place if they choose to do so. So here's a kind of call to action. Although most of us here are aware of frailty, many are not. And it's important to really spread the word. Really identify frail patients or clients, anticipate and prepare for challenges, and hope you can support frailty research to find a cure to prevent it, or evidence-based prevention management strategies, much of what we're seeing in this exciting world of Alzheimer's disease and related dementias, and work within our communities to provide services and resources for all older adults. You know, we're building the world in which we're all growing old, and the hope is that we're going to do it right. So thank you.
Thank you, Dr. Fain. That was terrific, and right on point for today's theme. I wonder, Dr. Fain, would you mind if Dr. Anderson and I joined your question and answer session, and maybe we could start to open things up, and we will prioritize questions that come in about frailty first.
Oh, absolutely. I'd love it.
Okay. Alan, do you want to turn on your camera and join us, and we'll start the Ask the Expert session a little early. But I had a question, Dr. Fain, which school do you ascribe to, Freed or Rockwood? I know that's very...
I invited that question. I'm a Freed devotee. I think it's biologically based. That's the tool we use for research. In clinics, I think anything that identifies a vulnerable population helps us provide better care. So anything you use, I support.
Do you measure and monitor serially walking speed and grip strength? Is that something that you teach the fellows and that you actually practice in your care of older adults?
That's a great question. We teach our fellows, we teach everyone about Freed. In our geriatric clinics, we use the Frail scale, which is a modified scale. It sort of has some components of biological and cumulative, and it seems to be an easy scale that has a pretty good sensitivity.
What about what is it called? The get up and go? Is that something that
the
you would
tug.
recommend? The tug, yeah.
Yeah, the get up and go can be a surrogate measure. It misses some of the things. Again, it depends. Right here at the University of Arizona, Dr. Joseph, created the trauma-specific frailty tool for trauma patients. So I think what's happened is every discipline, every specialty, that's why there's 75 of these scales, has been able to identify a scale that works for them. In primary care, something like the frail scale along with a walking speed, I think is a great combo.
There's some questions coming in, but I have another question for you that I think people would like to hear your response to. And I know this is of interest to you. So people need knee replacements and hip replacements.
Yes.
And they often are frail.
Mm-hmm.
What are your recommendations for other physicians on this call or allied health professionals who have frail patients who are going in for elective joint surgeries? I mean, this is tough.
I could have actually, it's tough, but not so tough. And I'm glad you asked that question. So the American College of Surgery and the American Geriatric Society got together to define sort of what are some things that should be done in terms of the assessment of the older surgical patient for just this. And frailty is one of those things that's recommended for any older patient who's undergoing intermediate or high risk surgery. So the surgeons are very open to this. And so here, if somebody was going for surgery, they would, and if they're identified as frail, they're rerouted in a sense to a nutritional and rehabilitation program. We don't have the full data to say if that works, but we take it seriously. And we also make sure the person knows they're frail and they have an increased risk of complications. So it helps on both ends. Does that answer your question?
Yeah, no, that's fantastic. Thank you. There's a question here. It's what can I do for my frail patient after I identify them? What do you recommend?
These are great questions. So it depends. Depending on the patient, some people suggest using the word resilience. I don't see resilience as being the opposite of frailty, but some people respond to the word resilience in a better way than being told they're frail. Just like genius isn't the opposite of dementia, or I guess Dr. Anderson would agree that genius is not the opposite. Resilience is not the opposite of frailty, but it can help. So we can say to patients, look, we did this scale or something, and we have reason to believe that you might be more at risk for things, and there's ways we can build your resilience. And sometimes in that way, and then we talk about what's important to them, what we mean by poor outcomes, vulnerability. Avoid harm, so what matters most becomes really important. Physical activity, chronic disease management, avoid hospitalizations and ED visits. So we really want to wrap their arms around these folks. If you have access to an in-home primary care program, that's best, or a home-based primary and palliative care program.
Great, thank you. That's terrific. Dr. Anderson, I'm sure that you're seeing a lot of frailty in the patients who come to the Banner Alzheimer's Institute for cognitive evaluations. Just thoughts about the intersection between frailty and cognitive decline, and maybe you could speak to Dr. Fain's mention of the concept of cognitive frailty.
Yeah, so no, we do see these patients. I mean, it's pretty common as the dementia patients are getting older, right? And when they get into their mid-80s and older, they're often going to have frailty. Very important point too. I learned some things from you, Mindy, so thank you. I always thought that we should buy some of these things to have, like the hand grip strength or tool and other things, but I'm going to look up some of what you mentioned today. In terms of cognitive frailty, interesting, Jordan. It's a concept I haven't thought about before, but obviously, just even normal aging has some takeaway in terms of some of the, especially the executive functions, working memory, speed of processing, and things like that. So my thought is, as people age, that's going to increase their chance to have more cognitive problems if they have some of those age-related cognitive deficits.
Yeah, there's even a third school. I didn't want to complicate things, but it's called cognitive frailty, and there's a number of people who ascribe to that. I would recommend, if one can do the Fried scale, to do it. because it'll give you a much more accurate group of those folks who are at high risk. And we have extra dynamometers here, Alan. I can loan you one.
All right.
I think that for people who have advancing symptoms of dementia, they're certainly, I mean, it makes sense that there's an increased risk for frailty because of planning, apathy, so not moving as much, not exercising, not using their muscles and joints, and not maybe being able to plan or healthy meals with high protein.
You know, I would say it depends on what scale you go by, because if it's biologically based, we know that there's inflammation, other things going on. Certainly people will be more frail based upon the Rockwood, but it may not make sense if they, you know, so it's hard to figure it out. I hope you all decide to work on it.
Has anybody looked at like anti-inflammatory diets in this population?
Sure. Yeah.
Do you know of any anti-inflammatory or specific diets other than high protein, Mindy, that have been studied in preventing or treating frailty?
There's been a tremendous amount of work on so many interventions and with very little success. It's really physical activity and stands out, and chronic disease management stands out.
Does a high protein diet without weight resistance actually reverse sarcopenia or prevent it? I mean, it seems that you actually need to be using your muscles for it.
You need to be using your muscles too. And the high protein, older adults need higher protein as they age. Just forget frail or sarcopenic. Most older adults don't take in enough protein. So the combination is what's needed.
Thank you. There's been some focus on caregivers. I'm so glad at this webinar today. When I'm meeting with the family, so usually it's an adult child or the spouse of somebody with dementia, it's part of my workflow to ask how they're doing, if they are burdened or stressed, if they are depressed, and if they are having problems sleeping. And it's just built into my DNA to ask these and then to help them if they need it. And I'm hoping that the two of you could speak to this about explicitly asking caregivers when they're in the room how they're doing, and if that's part of your workflow.
Well, I'll say that we, when we're training, when we ask about care, we include it as a problem, or we try include it, caregiver burden, caregiver, whatever it is, because it does, wonderful talk earlier, it's associated with all those other complications. So we consider it a medical issue also. Well,
that's a really great, that's important information for this audience, because if you're documenting it, it adds to the complexity of the note and is important for our billing. And so thank you for sharing that. Dr. Anderson, can you comment?
Sure. No, this is something obviously that we do all the time at BAI. You know, I think that's where maybe training in psychiatry gives us a little bit of an edge. You know, we can pick up things from the person's affect, the caregiver's affect, their speech and other things that might indicate a more severe depression at times. And so I always ask about stress. And we, as you know, at BAI, we have this very comprehensive program, and we have social workers who do work with the spouses and families, and we pride ourselves on, and I will often tell lay public when I give talks that, you know, when you treat Alzheimer's, you're really treating two patients. You're treating the patient and you're treating the caregiver as well. And they need to be referred sometimes for specific psychotherapy and some other services, and we really need to take care of that. That's very important.
Thank you. There's a question here that I think is related to Mindy, your larger work at the Aging Institute. What is the evidence of mitochondrial dysfunction and frailty?
There's a lot of hope. I mean, I would say that there's very little evidence for mitochondrial dysfunction, except when the first cohort, with the first frailty cohort was identified, it was clear that there was high levels of inflammation. And that gave credence to the fact that there was something biologically going on. And it's, you know, there are studies going on now looking at certain flavonoids to look to see whether it changes frailty. We have had very little advances. I would put us to maybe, and 20 years ago with dementia work. I mean, a lot of hope, but we're back to physical activity, nutrition, connection with others, and manage your chronic disease. It's almost the same menu.
Thank you.
So studies going on, no evidence.
Okay.
And Jordan, I think there's a researcher in Pittsburgh, Eric Erickson, who really looked at like even some animal models which show increased mitochondrial function as a result of physical exercise in the brain. So yeah, I think that exercise to me is going to be the best thing we can tell our patients to do.
Yeah. You remind me of an important point. There is no animal model really of frailty. There have been attempts. We have one here, Janko Nikolic created, I think one of the best mouse models for frailty. And so hopefully that will allow some more studies, but we're limited by the lack of an animal model.
Oh, can you briefly say what are the symptoms that the frail mouse shows? Is it encyclopedia? Is it cognitive slow? What are they doing? They walk slower?
I'm going to answer you directly because I was part of the conference that decided what are the mouse, what do we do? And it's grip strength. So they kind of let the mouse grab onto the edges and then pull on them, or they have them hang from the ceiling and see when they drop, how much they are on the wheel. It's very specific, that consensus agreement on mouse models of frailty.
Cool. Great.
Yeah.
There's a question here. Have new antidepressants been studied in older patients? So this speaks to something that Dr. Tariot said, that phase 3 trials that bring a drug to market don't always inform how we care for patients in the clinic. Mm. And so FDA registration trials use younger patients. And I showed we're recruiting for a project right now using a novel mechanism drug, but the age range is 18 to 74. And it's too complex for drug companies investing all of this money into these clinical trials to have people with maybe a limited lifespan or just complex or unstable medical conditions participating. So it requires phase 4 studies to better understand how drugs work in different populations. So when you ask about new antidepressants, maybe you're asking about ketamine or S-ketamine, the intranasal formulation. And yes, there are ongoing studies using these drugs in older adults, and other newer medications like brexpiprazole or vortioxetine. There are phase 4 studies that are studying these in older adults. I will say that one of the things that's important about studying antidepressants or psychoactive drugs in older adults is not just their clinical effect or clinical benefit, but closer attention to safety with a focus on falls and cognition as well. So those are important outcomes that we attend to when we evaluate these drugs in older patients. There's another study, or another question, but this came from Dr. Fain. May I ask if you find that frail older patients are more likely to fall into the difficult to treat depression category? I will say yes, with a caveat that yes, they may be more difficult to treat. I think this is more the brittle depression response that I'm talking about. And we can still get these patients well, and my response should not contribute to clinical inertia. They just may need a little bit more attention and taking a step back and not relying solely on a medication to solve the problem, because it is multifactorial contributors to frailty. And we need to make sure that they're able to get out, be social, that they are eating well, because these other things are also contributing to their depression. There's a question here, have I prescribed TMS to older patients? Yes, certainly. TMS is effective in older patients. There is a bit of a question because TMS does not cause a generalized seizure like ECT. There is brain shrinkage, so the brain gets smaller. It's not as close to the skull, so there's the possibility that TMS may not penetrate the brain as somebody who is a younger, this is not the most scientific word, but plumper brain. But there is evolving and emerging technology with deeper TMS, and it does work in older patients. Let's see. while there are some services available in the community to support aging in place, how can we best advocate for the creation of more services to meet the growing demand? Great question. I'd like Dr. Fain and Dr. Anderson to take turns and try to tell us how to save the world.
I guess I'll start. First of all, thank you for that question. That's probably the most important. We know that every community has an area agency on aging and, other services, resources within each community. Different health systems provide stuff, but we need to really all come together under umbrella and decide that this is important. So that's the more like the right thing to do bucket. The other bucket is that if we do it right, patients and families will be happier and the cost should go down. We know that from from our studies for taking care of seriously ill and older or frail, disabled, older adults in the home, that if we provide team-based primary and palliative care, that we improve health outcomes, reduce costs by about 15 to 20% for the whole system, mostly by reduction in utilization, unnecessary utilization. So there's a business model too, but we all have to kind of have the same payer. I hate to be so blunt about it, but as a community, if we see ourselves as one payer, then providing services makes sense as the right thing to do and value-based, cost-effective.
Thank you.
Yeah, I'll make a couple of comments, Jordan. It reminds me, I'm preparing to give some testimony at an AMA meeting in a week as part of the House of Delegates on a resolution raised by the senior physician group. And it concerns the availability and access of assisted living memory care programs. This is one of the areas that as a society, we need to figure out. I mean, we do not, memory care assisted living is basically a cash-based service unless you happen to have long-term care insurance, or you go to a facility in Arizona that takes Altex to support that. But our population of dementia is going to grow so much, and the need for more affordable, accessible care in terms of memory care units, but also in terms of ambulatory services with dementia daycare programs. I mean, this is really something we need and can really benefit our population. But unfortunately, it's just not something that insurance covers well.
Thank you. Thank you both for those answers. I will give people an easy thing that they can do to support change. And that is belong and pay the dues to your professional organization. So the American Psychiatric Association, the American Medical Association, the American Association for Geriatric Psychiatry, social work, pharmacy. Some people say, well, I don't know what this is doing for me. Like, what's the point of belonging? Well, these organizations pay for lobbyists. Right. They are looking out for patients and their members, and they are the major drivers for advocacy change at both the state and the national level. So it's something to keep in mind. There was a question here about for Dr. Anderson. Do you have a short scale you recommend to screen patient outcomes? So I guess it's to assess change in managing behavioral and psychological symptoms of dementia. The neuropsychiatric inventory scale is lengthy, I would agree.
Yeah, and I think most of the scales are not easy because of their length. So, I mean, there's the Cohen-Mansfield agitation inventory, there's a Pittsburgh agitation scale. There are a number of these scales, but they do take some time. Basically, I think what I ask caregivers to do is keep a journal of, how often are hallucinations occurring? How often is the person being agitated and aggressive or resistant? And just, being able to journal that and bring that in so that I can see, okay, we're going in the right direction. But I don't think there's a real easy scale to use for agitation and dementia. That it doesn't take some time. And caregiver burden would be another way. And there's a caregiver burden scale that you could give and have your caregiver do it while they're in the waiting room or before they come in for the session. It could give you a sense that once you initiate a treatment, it's caregiver burden going down, because that's going to be an important way to measure that.
Thank you. Alan, there's another question here. Are there symptomatic treatments? So I guess not disease modifying, but symptomatic treatments for Alzheimer's disease in development that you are particularly excited about?
There's one that we're studying that I'm excited about. It's a single molecule that supposedly has a hypothetical way of stopping the movement from amyloid to tau, the amyloid cascade, but also reducing inflammation. And that's a study by a company called Cassava. We are doing that study currently, and it's an interesting agent. Other than that, I'm not really familiar with any others, but there are probably, you saw what Dr. Tariot presented, how many studies there are. I'm sure if you looked at that, you'd find some other things.
Good, thank you. We're nearing the end of our time, but we'll take a couple more questions. And any special guidance for these issues with patients with visual or hearing impairment who have dementia and or frailty? I think this is a really great question. And Mindy, do you want to talk about how you address sensory problems?
Well, I thank you for this question. In general, with older adults, we pay attention to vision and hearing. The huge number of older adults have impaired hearing and use other strategies to hear what's going on, even in the office setting with others. We always want to make sure that we're not backlighting where we sit in a room, that they can look at our face and look at our features. And that's particularly important with folks who have cognitive impairment. And to make sure that they can have all the sensory input that they can. With hearing impairment, general strategies, lower your voice, speak to them, don't yell, because then they lose any ability to read your lips, cognitively impaired or not. And we use hearing assist devices. Those are those
The pocket talker.
Yeah, the pocket talker. And we can pop one in there. Incredibly helpful. Our teams carry them with them and are helpful. I think that's
great. Thank you.
That's my list. I do want to say that most visual hearing impairment and cognitive impairment is missed in primary care clinics just because of everything that everybody's juggling. So a special call out to make sure that your processes in your clinics include a way to assess those. The annual wellness visit is a way to do it, but just to recognize that we miss it.
And there has been data to show an increased risk of Alzheimer's in patients with not uncorrected hearing loss. So we really need to make sure that gets fixed. It's easy for me because I wear hearing aids. So I'll tell the patient, look, if I can wear hearing aids due to my rock concert attendance in the 70s, you can wear hearing aids.
Right.
There's evidence that uncorrected hearing loss is also a risk for depression and can interfere with effective depression treatment. So.
Wow.
Well, we're nearing the end of our time, and I want to offer you both the opportunity to share like 1 to 2 pearls or closing statements, because you've both been such gracious and generous hosts or guests to this event. Go ahead, Mindy.
Oh, just thank you. This was great. And if we spread the word about frailty and aging in place, that's awesome. Just think about, I'm a resource. Feel free to email me. And hopefully you'll look to identify your frail patients and help them age in place.
Thanks. And Alan, before you speak, I'm going to give you your chance, but I don't want people to sign off yet because we need to still tell you how to do the evaluation and get your CME and CEUs. But now I'll give it to you, Alan.
Sure. So I think my take-home point, and I hope you got this from my talk, is that not to quickly jump into pharmacologic strategies to manage agitation. You want to make sure you take the history and listen to what's going on, because so often there are things you can do that have nothing to do with throwing in medicine at a patient. So really think about that DICE approach. Think about trying to identify triggers, and let's look at this, right? If we can manage people without medicines and avoid side effects, drug-drug interactions, polypharmacy, very important.
Thank you, Alan. Yeah, good. All right. Well, again, I want to thank all of our presenters, and I want to thank all of you, our attendees, for taking 4 hours on a beautiful Saturday to spend with us. I hope it was worthwhile for you all. We're really grateful that you honored us with your presence, and I wish you all a wonderful weekend and lots of good health. So take care, everybody.